Good morning, everyone. Welcome to Devex CheckUp at WHA 77, our third year in a row hosting this event here on the sidelines of the World Health Assembly at the Intercontinental Hotel. Thank you so much for everyone who's joining us here in person and for those of you joining us online as we kick off 2 full days of events. I know there are a lot of things happening this week, a lot of choices of things to go to, so we are very delighted that you've chosen to spend your morning with us. Something that makes our Devex Summit a little different from the other events you'll see here this week is that it's really developed and led by our journalists. Who here is subscribed to Devex CheckUp, our global health newsletter? Great, love to see it, and that's my plug to sign up if you aren't already. But you probably are familiar with the women who are behind Devex CheckUp, who will be here on stage conducting these interviews, helping to break through the noise, get past the PR talking points, and really maybe even break news here on stage. So they might be household names to you. We have Sarah Jerving, Rumbi Chakamba, Janila Ravello, our checkup team here that will be leading us and guiding us through these 2 days where we're going to be focusing on 4 key themes. Rethinking healthcare delivery is what we'll kick off with this morning, and then we'll later move into adapting healthcare for a world in flux. And then tomorrow we'll reconvene on building resilient health systems and looking at the future of global health. We also have some other events with partners later this afternoon and tomorrow morning, so it's a really busy couple of days here. We would not be able to put on events like this or frankly do the journalism that we do without the support of our partners. And we have an incredible group of partners with us this week. So I want to give a special thank you to them, our impact partners, HemoQ, Evolution, MSH, or Management Sciences for Health, Nora Health, OneSight Esler Lexida Foundation, Qualcomm Technologies, Inc., Black Frog Technologies, and the United Nations Foundation. You will hear more about each of those throughout our program and all the exciting work that they are doing. We also have our ecosystem partners, Ferring Pharmaceuticals, ISN, or the International Society of Nephrology, Medtronic Labs, MSD for Mothers, and Roche. We will be holding other side events with them again later today and tomorrow morning, so hopefully you'll be able to attend for some of those. We do have some QR codes hanging around on some of these chairs, so feel free to look up. You can learn more about our partners and more that we do at Devex, including subscribing to some of our newsletters. So to kick us off today, I think something a lot of us are talking about is what is going on with this pandemic treaty. And you probably have read some of our coverage the past couple of days. Negotiations have stalled. I think there's real hope that we will be able to get to some consensus here this week. So I think it is a perfect topic for us to kick off on. And I will introduce to stage my colleague, Janila Ravello, to lead that discussion. Should we take it?
Hello. Okay, perfect. Hi, everyone. Good morning. Really excited. Thank you so much for that, Kate. I'd like to maybe just ask our esteemed speakers today if you can join me on stage and we can have the introduction while you're on here. All right. Well, I'm really excited to kick this off because I think for the past week or so, and even as of yesterday, I've just been at the Palais, kind of trying to figure out what's happening with the pandemic agreement. So today with us is Dr. Roland Dries, Director for International Affairs, Ministry of Health and Welfare and Sport, but also the co-chair of the INB, who's really done hard work very late nights in a lot of times to get us an agreement. And then we have Dr. Fifa Rahman, principal consultant at Matahari Global Solutions, and of course, she's been providing technical advice to the Africa Group on the negotiations. And of course, we have Dr. Magda Robalo, president and co-founder of the Institute for Global Health and Development. Thank you so much to our panelists for, coming here very early this morning to discuss this. Dr. Dries, I just want to start. I think it's on everybody's mind. What's the next steps for the pandemic agreement after you've not reached consensus last Friday? Can you try again? Yep.
Oh, now it is. Good morning, everybody. It's good to see you at this early hour of the day. What are the next steps? Well, basically, they're not in my hands, to be honest. We were, as a collectivity, as the IMB, we were supposed to deliver an agreement. But actually, we were supposed to deliver an outcome. That was the only mandate we've been given. Report on the outcome of your work. And of course, everybody had hoped that that outcome would be something complete that we could all agree upon. But as you all know, that's not the case. So the World Health Assembly today actually needs to decide what is next. And well, the options are rather straightforward. You can either continue with the aim of finishing it, or you could stop it. And that's all the flavors we have. And I presume from what I've heard from everybody, and if you also look at the concept resolutions that are circulating, is that most member states are opting for a continuation. And then the discussion will be for how long and in which format. Is it in the same format as we're having today, or do you want to change that a little bit around? Because changing the scenery is sometimes useful to get the energy back in or get the process going again where it's stuck now. And for how long? Half a year, 2 years? Those are the terms that you hear circulating. So I just look very much forward to that discussion and see what they decide.
I just want to build on that because as this morning, two draft resolutions are published on the WHA website. There's one from the Africa Group, and maybe FIFA, you can maybe talk a little bit about that. But then there's another one really from some high-income countries, and one of the proposals is to have a special session, hopefully before the end of 2024. So maybe can you talk about that? Like, what are some? Is it likely that we're going to have a special session, or will there be text-based negotiations happening this week alongside WHA?
Well, I don't think it will be wise to have text-based negotiations this week because, in my view, we're not going to finish those. The chances of finishing the discussions during the WHA are, in my view, zero. So why should you try to do that? Why do you push people who have been working very, very hard over the last 2 years into such a regime? That will not be my suggestion anyway. I mean, if member states say we're going to do it anyway, well, I can't stop them, but it would not be my advice. And then the idea of a special session, I think it's wise to take enough time to tackle those really sticky issues that are still out there. Because if you look at the quantity of issues, we've solved a lot. But if you look at the quality of the issues still on the table, they're not easy. They're about IP. They are about percentages that industry should be setting aside for delivery to countries most in need. They are on sanctions, for example. So there are really politically sensitive and difficult issues. And if you want to tackle those, you just need to take the time to really sit down with countries and see where there's room to maneuver and go to other countries and test those ideas. And if you just want to push them in another 3 months, it's going to be difficult to solve them, I think.
Dr. Fifa Rahman, because you're as a consultant for the Africa CDC, you've been providing technical advice to the Africa Group on the pandemic agreement negotiations. But before I move to the to my main question, I do want to ask you if you can comment on the resolution that's been supported by the Africa Group. If you can give some insights on that.
So it's going to be tough to provide insights on that without betraying positions. But I can say that I actually agree with Roland that perhaps the special session will be optimal because you're ensuring there's time to clean house, a little bit of time to have the conversations behind the scenes that need to happen. I think that the UK's non-movement on PABs because of political constraints back home is something to consider as in as regard the timing of the special session. The elections in the UK are July 4th, and while there's no guarantee that the positions will change after July 4th, I certainly don't see value in continuing right now while emotions are still high and while there's unlikely to be a political shift on the key issues that matter.
Maybe you can give us instead a behind the scenes look at what it's been like to provide technical advice. How challenging has it been to provide technical guidance, including negotiation strategies and textual proposals, to a group representing 55 countries that don't always see eye to eye?
Thanks for that question. So there's no way that we can expect a continent as diverse as Africa to agree at all times. So that's certainly not the expectation. My role has been to provide textual advice, advice on the legal effect of certain words and certain terminologies, as well as comparisons with other treaties. And identifiers on pathogen access and benefit sharing is one of those areas where the ABS system in the BBNJ, for example, the High Seas Treaty, it has identifiers, and we make a comparison there and try to understand why identifiers worked in one and why the Global North are claiming that identifiers might not work in another. But advice is also tactical. So the political economist J.P. Singh, he said that global South countries or developing countries can win through a combination of knowledge, cunning, and daring. And this can happen through a number of ways, right? There's coalition building, for example, where you ensure your coalitions are strong and you negotiate as a bloc. There's also stating that you're bound by precedent at the local level. And One Health is a good example of this, where you examine what Africa is committed to at the national level or regional level on One Health and see how much further you can go at the global level. And coalition building is particularly important, not just within Africa, but within the global South. And India and Indonesia supporting identifiers on PABs is an important one. And when we think about cohesion and strategically negotiating as a global South bloc, that's something that needs to be prioritized in terms of presenting a united front, not just on an African front, but a global South front. And it's also about knowing your opponent and not conceding too early. Now, these are opponents that spoke very highly of solidarity, but we need to remember that there were situations where close to expiry vaccines were transmitted to the global South, right? There's a lot going on Gaza, where we see rhetoric on one thing and practice happening in another way. So we need to ensure that there's protection that way, but strategically, tactically, all of these things matter. So the advice isn't just textual, but also tactical.
I just want to follow up on that because you used the term opponent, and I guess looking at the group, it was supposed to build cooperation across different countries. Why do you think did you use the term opponent in this case?
I think because positions are diametrically opposed, and there may be a lot of talk about, oh, we all want the same thing, but where we are at on PABs, for example, where some countries want up to a certain percentage, some don't want a percentage, others want at least. When the numbers on things just don't, the numbers, for example, AstraZeneca produced 3 billion vaccines in 2021. That's just AstraZeneca. And the Telegraph articles that caused such a furor about 20% of British vaccines going to foreigners. 20% of 3 billion, how much is that? I'm not going to do the math right now, but Britain only has 69 million people. Britain does not need 3 billion vaccines, right? So calculations-wise, we need to think about whether these countries really want equity or whether we're arguing on diametrically opposed planes.
Sometimes when we discuss the pandemic agreement, especially when I speak to experts, it gets very technical. We talk about PABs, and sometimes my editors would say, "Explain what PABs is to me." We talk about one, I'll explain this to me. But I think I do want to ask Dr. Robalo, because during the pandemic, it's not just about access to vaccines, diagnostics, and treatments, right? It's really impacted health systems. It's impacted health workers, right? It's impacted communities. There are other dimensions other than access to medical health products, which are, of course, important. But I do want to ask you, how do you see, I know we don't have an agreement yet, but how do you see this impacting health workers, social context on the ground, beyond just access to medical products? What are the key provisions that you see will directly affect frontline responders and local communities?
I think the entire treaty needs to be looked at in a holistic way. Each clause has some impact on the other one. I think, let me just move back a little bit. The pandemic was a real test of how much apart the world was when it came to solidarity, equity, caring for each other, and being able to work together in global cooperation to prevent a disaster. So after the COVID, we had a small window of opportunity where everyone commented, and we still comment on how bad it was that we failed to support those who needed support from the global north more than anything else. But then this 2 years journey of negotiating the treaty brought back the realities that we are far apart. The clauses of the treaty in its entirety needs to be based on equity. Each line, each word needs to be crafted in such a way that we protect communities, we protect health workers, and I think no matter how difficult it will continue to be, we have made progress in terms of discussing difficult issues, discussing the need of health workers being protected, having better conditions of work when it comes to outbreaks and pandemics, being supported with training, with protective equipment, IPC, etc., being recognized as the frontliners, and pandemics and outbreaks starts in communities and end in communities, as we say. So they are really the most important agents. And what makes me a bit sad about where we are right now is the fact, for example, that gender or women are words that have been a reason for contention between the sides negotiating. Yet the health sector is majority made up of women. 70%, sometimes 80% of health workers, particularly community health workers, are women. And the treaty, one of the points that countries can't agree on is on how much of women or gender could be included in the treaty. So it is going to be important for us to agree that these service provision health workers need to be given the conditions of work. Many, my country, for example, one of the major drivers in many other places was the lack of infection prevention and control, which was driven the pandemic. We need to make sure that this doesn't happen again.
I just want to build on that because here we feel like we all have a sense of what the pandemic agreement is, but to what extent are people on the ground, nurses, local community leaders, aware of this and its potential implications for their work?
I don't think we are having bottom up discussions. I think very little filtered down to those who are the first concerned by the outcomes of this treaty, unfortunately. And we need to make sure that countries, as soon as possible, give feedback, consult the communities, civil society, private sector, the communities in the countries, particularly the global south. They need to be aware, and we need to combat misinformation so that people know exactly what we are talking about, what we are discussing, what are their concerns, what are their needs, and how much governments are fighting to get them protected. There is very little information filtering down, and that's a danger because we have seen how misinformation has been bad for us to combat the pandemic. So we really need to work down to getting people informed and give feedback. This treaty, I must say, is a first step in a long process. I think just as we have seen with the IHR, after a while we had to renegotiate it to tighten some of the clauses, make it clear, and make it more usable, more effective for people to be able to implement it. I think if we get a treaty, I agreed we shouldn't lose momentum, and no matter how difficult it is. And we know there are issues that probably will not agree upon, and some, even if we do agree, it's not given that countries will enforce. Implement them when if a pandemic hits. So it's yet to be seen. But I think it's better we have at least some common ground and then be better prepared than we were when we started. For us, there is no other compromise. Equity should be on the first line throughout, and that's what we demand. That's what we think the world deserves. We cannot talk about global solidarity, cooperation, if we have close to expiring vaccines being sent for us to just put them on a bin.
Dr. Dries, this been a really long, well, for some not really that long, but it's been 2 years plus process. Could you provide insights into the evolution of the negotiations? Share with us some of the challenges and opportunities you've encountered.
Yes, when we started this was still in the aftermath of the COVID crisis. And then it was pretty obvious for everybody that we should do this. And world leaders came together, they wrote open editorials in the New York Times, I think it was, and everybody agreed that it was one of the most important things in multilateralism we could do. And what you see, and I think it's also understandable in a way, is that with time progressing, that urgency is slipping because there's so much in the world that's going on that requires our attention. So it's really a challenge to keep the urgency at where we want it to be. So that's one of the challenges we see and we face. But if you say in terms of progress, I think we all have to realize we started with nothing. We started with a blank sheet of paper, and if you see where we are now, I think we have all the elements on the table. We have all the elements on the table that you have to address when you want to do better as a world community in addressing pandemics. You could argue if it's not too loose, if there's too many voluntaries or too many as appropriates in there. Well, that is just what it is. But I think all the elements are there, and if countries want to work with them, they can work with them. So I think that's a major step. But a treaty is still a piece of paper. It's not Harry Potter's magical wand that changes around the whole world by adopting it. And it's what Mike Ryan of WHO always says. This is a starting point. This is if we, whenever in a year's time maybe, agree to this, you have a platform or something to relate to as a global community to address pandemics. And if the percentages are not right yet, okay, let's start working on these. And then there's discussions on should prevention be stronger, should One Health be stronger. I understand that when countries are in this arena of the IMB and discussing and trying to make their points and getting their points and take them home and present the results. But in my view, you should look at it. The most important thing is that there is prevention in there, is that One Health in there, and that everybody says there is no discussion that it's important to invest in these things. And maybe not all countries are able to do that at this stage. But we also say in the treaty, well, if you're not able to do this, there's technical provisions, there should be financial provisions in place to help you do that. So what I try to say is that we started with nothing and now we have something on the table. When we agree to it, is really a good foundation to start improving the world, but it will not improve the world the next day. And I think we should, and I think everybody realizes that, but sometimes in the height of it all, sometimes you forget about that.
I know Dr. Robin wants to chime in, but maybe just a follow up, and I'll give this the mic to you. But I just want to build on that because you said, you know, if you look at where you started and where you are at the moment, there are some questions, and maybe you can address this. Why text-based negotiations just started, like, I think last month? There are questions around that. And at the same time, maybe you can talk about transparency. Dr. Robalo was mentioning earlier, I was asking about, you know, how much do people on the ground really know about this? How were conversations regarding transparency conducted with member states? Was there any conversation to, you know, let's increase transparency on what we're really doing here to combat misinformation surrounding this treaty?
Well, those are two different questions. I think one is them in the how do you conduct the negotiations? And it's not that we did not, I mean, we spoke with each other for 2 years in all kinds of formats, informally, formally, in big groups, small groups. And some say we should have text-based negotiations. Well, to be honest, I know they're part of the negotiations, but text-based negotiations are not solving the difficult issues, because then you're going to fight over words, over sentences. I mean, if you want to have a breakthrough on a percentage that should be included, that's not going to be found by text-based negotiations. That is sitting down with countries and saying, how far are you prepared to go? And maybe that's not what others want to hear, but you have to, I mean, out there in that meeting room, people are just going to state what they are told to state, and that's not going to bring the solution. So I'm not so worried about that we start late with text-based negotiations or anything. The other issue is transparency. And we try to be as transparent as possible. All the different iterations of the text we have are all on the WHO website for everybody to see. But we also know there's a lot of mistrust, fear, miscommunication, all those things. And maybe just one example, because people approach me as well. And there was a woman in the Netherlands who wrote me an email, and she said, what is this all? And why are you doing this? And this is so bad for the world. I said, but have you ever, because normally we don't react to it, but now I thought, why don't I just react to this lady? And so I wrote her an email back, say, well, very good that you did this, but why? What are you afraid of? Why did you get, what are your sources? Have you ever tried to read actually what it is? And then it turns out, of course, that she never read what was in it. And I said to colleagues also, if one of the things that I've discovered this past 2 years, and that really frightens me a little bit, is the sheer number of websites and so-called online TV shows and that just thrive and live from misinformation, and not just on this, but this is something that I follow more than other subjects. Somebody sent me yesterday a little video of a German show, and it looks like a proper 8 o'clock news broadcasting scene, and it's just people dressed up like me, very, very, well, whatever you want to call this, but presenting things very seriously, and then saying things that you think, my God, what are they saying? And but a lot of people like this lady, they follow that, and they just do not bother reading what's really going on, and that's really concerning, and that goes much further than the pandemic treaty. But that's just one of the things they use, and that's a little bit something that frightens me when I'm in bed at night. Thank you.
Dr. Waldo, I think you have. Do you want to come in earlier?
Yes, I just wanted to comment on the issue of trust and mistrust, and the fact that financing is one of the most contentious issues in these negotiations, and having words like prevention, preparedness, response, implementation, etc., is good, but it is only as good as they could be backed by financing. They may turn out being empty words if the critical issue of who pays for what and when do you pay, after you have satisfied all your needs, what strings are attached to the funding that is being provided, those are critical issues. I think we see all this riding on the back of multipolarized world, and we also need to see how much of all this will end up being regional blocks or cross regions negotiations of bits and pieces of a treaty. And I think transparency will require that we also put all this on the table for us to see where things are coming from and where they're going to go. The old man in my village would like to be able to access healthcare if Ebola or any other outbreak starts. And that's where also we need to make sure that universal health coverage is at the center of this treaty.
We can discuss the whole issue around funding for another hour, maybe. But I do want to open this to maybe 2 questions. And I want to start with Agre Aluso, Director of the Africa region of the Pandemic Action Network. Agre, please.
Thank you. Thank you very much, colleagues. And thanks, panelists, for your very, articulate, open-minded contributions. I think we're all very concerned and we're hopeful. We've been joking with colleagues how we were hoping to be popping champagne bottles, celebrating an agreement, but we're not there yet. But I think encouraged by what Ronald said, that there's no contention about the need to get this over the finish line, however later or sooner it may be. So that's encouraging. But really, one thing that I think humanity hoped for, and I come from Nairobi, Kenya, and everybody knows how this panned out, so I'm not going to belabor explaining how it did, but I remember very vividly when a priest from Italy came back home at the start of the pandemic. And by that time, we did not, it was not like a real threat, so they thought. And this priest went to a village, my village actually, to preside over mass. There was, it's celebratory mood, he'd been away, he came back, and then he tested positive. A few days later, and there was panic in the village, some far-off village in Nairobi, in Kenya, northwestern Kenya, of a pathogen that emerged in Wuhan, China. And just showed how interconnected our world is, and the threat somewhere very far off from your reality can be a threat to you in no time.
Do you have a question, Agre?
Yes.
Do you have a question?
I have a question.
Yes,
So my question is, what would it take for humanity to really learn their lessons? Because this was our moment of reckoning, our moment of reflection, to really, everybody is emphatic that we cannot continue doing business as usual, and we really need a reset of our global normative framework. Yet the most important things that we need to drive forward, which is equity, as Dr. Abello said, and solidarity-based solutions, not market-driven solutions, because that failed us. What will it take to really draw the line and say we must act in solidarity for humanity and global health security?
Maybe very briefly to the three panelists, if you can start, maybe Dr. Roballo, very briefly.
I think it will take leadership, brave leadership, from at least the part of the world I come from, to stand on principles that are non-negotiable. And like I said, equity is non-negotiable. We don't want to find ourselves back in 2021, and there are critical issues that need to happen. Like I said, communities, not commodities. We need to put communities at the center.
Yeah. Dr. Rahman, very quickly.
Very quickly, is just to agree with Roland on the fact that textual-based negotiations are not going to get us to solidarity. Nothing is negotiated in a silo, and any negotiations nerd knows this. What we need is to have those difficult conversations on what will you give me for this? And that's happened in many other negotiations in the TPP, for example, when New Zealand said there'll be no deal on biologics until there is a deal for dairy. And we need that conversation to happen here.
Dr. Trace, the last word.
Yes, well, there is always the world that you want to see and the world that's out there. And those are not always the same. And the pandemic treaty is not going to change that either. I think that we will be doing better when we have a pandemic treaty. That is, like I said, a foundation for further work. But I hope I'm wrong. But it's not going to change the world tomorrow.
Well, thank you so much to our esteemed panelists, really, for these insights, and perhaps a round of applause, please. Thank you.
If you have a seat open next to you, would you mind raising your hand so maybe a couple people in the back can find a seat up here? Great, thank you. It looks like there are a couple up here. Well, we are going to continue the conversation, taking a look at the act of caregiving in partnership with Nora Health. But to kick us off, we would like to start with a short video that I'll ask our team to tee up and play, and then we'll continue with the conversation.
In the quiet, difficult moments of life, where love meets action, there exists something profoundly human, a subtle act of care. Caregiving is a universal act of love. It's the little and big things that we do to help each other. In those early mornings and late nights, hoping for recovery, a moment of comfort, or a future that's healthy. Yet amidst these gestures of love, family caregivers, often women and girls, face complex challenges and are met with isolation, financial stress, anxiety, and so much more. Now imagine a different world where caregivers are no longer taken for granted and where we feel confident and supported by the systems around us.
I think that tees us up nicely for this conversation around really the importance of family caregivers as part of our health system. To kick us off, I'd like to invite Edith Elliott and Dr. Syed Alam, both co-founders and co-CEOs of Nora Health, to come say a few words.
Thank you so much, Kate, and thank you everyone, especially our distinguished panelists, for joining us on this special conversation about the power of family caregiving. I imagine everyone in this room has either been a caregiver or has been cared for by someone that they love, whether it be a parent, a friend, a neighbor, a partner. It is due time for us to honor and respect this deeply complex and personal act of care, and to develop systems that better equip and support the people who help us heal.
And I first met and started NeuroHealth about 10 years ago, we were driven by the belief that loved ones and family caregivers were one of the most important elements of care. Yet they were unseen and unsupported largely by health systems around the world. But when family caregivers are supported effectively, we've seen that their burden is relieved, but also the patient's outcomes improves. We've seen in our work that there's a reduction in newborn readmissions by more than 50%, a reduction in post-surgical complications by 70%. So as we all strive to meet the SDGs, we believe that there's tremendous opportunity to fill these gaps by better recognizing and supporting loved ones and family caregivers. And to that end, we're incredibly honored to have the visionary leaders here with us today to share their perspective and approach. Thank you.
Yes, thank you both. So I'll invite our panelists up to the stage here. We have His Excellency, the Honorable Mr. Budi Sadikin, the Minister of Health from the Government of Indonesia. Thank you. And Dr. Anshu Banerjee, Director of the Maternal, Newborn, Child, and Adolescent Health and Aging Department at WHO. We have Mohammed Mamanur Rashid, Joint Secretary, Health Services Division, the Ministry of Health from Bangladesh. Dr. Neha Garg, Director of the National Health Mission and Mental Health Ministry of Health and Family Welfare in India. And Dr. Sham Syed, Head Policy and Partnerships, WHO Special Program on Primary Health Care. So real powerhouse group of experts here. Thank you all so much for joining us for this really important conversation. And I'd like to start with you, His Excellency, Honorable Mr. Budi. Under your Honorable Minister's leadership, Indonesia's health ministry has really started an ambitious health transformation across multiple areas. So can you talk about how you see supporting family caregivers as part of that transformation agenda?
So I'm in Indonesia, I'm a banker by 30 years, so I'm a nuclear physicist by training, so zero background in health. So you have to feel sorry for me that I'm sitting here in comparing with all of you. But let's get in the last 3 years, I only have been in this job for 3 years, and I have 6 months to go. I noticed that promotive and preventive is much more important, it's much cheaper, it's a better quality of life than if you wait until you need a curative programs. So that is my first belief. My second belief, when you want to do healthcare intervention, especially like in COVID, you cannot do it alone. You have to do it together. You cannot do it exclusively the program of Ministry of Health. You have to do it inclusively. You cannot approach as a program. You have to create a movement. So that is the reason when I want to do the interventions related with family care, I realize the government structurally, we have 38 provinces, 514 cities, 10,000 districts, 85,000 villages, and 300,000 hamlet. Our healthcare, national healthcare facilities owned by the government stop at the 10,000 districts. With my predecessor, great thinker of health. But I want now, with the healthcare reform that we are doing in the last 2 years, we want to push it down to 85,000 villages, basically owned by the government, run by the government. But I want to inclusively create a movement, not only put it at 300,000 hamlet, but to 68 million families. Why? Because I don't know in your country, but in Asia, the mothers is very compassionate. I believe also all mothers very compassionate. They will take care of the husband when they're sick. They will take care of the children if they are sick. Even sometimes they take care of the dog and the cat when they are sick. And they never ask for any payment. They do it because of their heart. So if we can mobilize, facilitate, you know, make all 68 million mothers of Indonesia not only understand how to handle fever, but putting a thermometer and give you a pill or syrup, or cough, they can give it syrup. They can pay doctors all the time, but only for three things: yeah? Fever, diarrhea, and cough. If we can tell them, hey, this is the way you can put the hypertension, and if your blood of tension of your heart rate is about 130/90, you go to the nearest puskesmas, primary healthcare facility, and they can give you free amlodipine. But you have to make sure that your husband consume that every day. Otherwise, you will very, very mad to your husband, and I know every husband are afraid of their wife. So they follow. So the concept of motivating using the wife, 68 million, to be my first healthcare provider to families. I think that is a dream that I would like to do.
Well, I think you so eloquently put out there, you don't have to be a healthcare worker to be impacted by the need for caregiving. And Dr. Anshu, that's probably your learned that you should be here, so you're in the right place. You oversee newborn, child, adolescent health, and aging department at WHO. And caregiving really, it can start in the early stages of life and the later stages of life. And many families find themselves in that, sandwich generation where they're caring for young children, aging grandparents, all within the same household. So how does WHO prioritize caregiver training and support across all of these stages of life?
Thanks very much. And as you highlighted, caregiving indeed goes across the life course. And I think it's very important to realize that. One point I wanted to highlight actually also is the whole issue around gender and caregiving. Because what we see, particularly later in life, is that it are often, most likely because they are very compassionate, but it falls on the women to actually provide care, whether it's care for the sick child, whether it's care for an older adult in the household, whether it's for their parents. And this actually also means that it is them who lose out of their contribution to economic growth of the country, but also for themselves, their own career, and potentially later in life also from social benefits. And because social benefits are built across the life course. And so if women sacrifice their career as they let's say, age and then are in a situation later in life when their husbands have passed away, their pension actually has reduced. And so it has also got economic impacts, I think, on women of being that carer throughout the life course, and it's something to look at. Often also, we know that it is the caregiver who needs care themselves. We have older women who are taking care of their older husbands, let's say, but they are already in need of care themselves, and who is there to provide that care to them? So there are a lot of, I feel, gender-related issues around caregiving that would be useful to highlight, and would be interesting to look at that from an economic cost as well. And so it's important in society that I think caregivers are both men and women, fathers and mothers, husbands and wives. And from that perspective, it's important to be able to provide them with the right kind of competencies in order to do that. So, for example, we're looking at, when it comes to child health, at the well-child approach, and really looking at what does that mean? What is the role of parenting? And the COVID pandemic, of course, has also really shown what the role of parents can be in the well-being of their children. We've seen, situations of social isolation of children during the pandemic. We've seen that parents actually had to take on schooling at home because children couldn't go to school and be in classrooms in person. And so the role of parents, I think, has been elevated, or the parenting skills that they need to have become more visible during the COVID pandemic. So I think from that perspective, it's really important to see how to take that forward. And so from that perspective also, as part of the Well Child approach and nurturing care for early childhood development, as well as for adolescents, we're really looking at what are the skill sets, the competencies parents need, and how can we provide them to them in order to have, in order for the child to develop as optimally as possible.
I'd be curious, how many people in the room have served as a caregiver to somebody in their family? Yeah, I mean, it's almost the full room in the panel. So, Mr. Mohammed Rashid, I'd love to hear about some of the challenges you face in your country of Bangladesh in supporting caregivers. And maybe do you have any examples of programs or interventions you've been able to deploy to help support caregivers who are often women, often underpaid, underappreciated?
Thank you very much. Actually, the COVID pandemic situation we have learned much more from the COVID pandemic situation that only healthcare system, the routine healthcare system is not enough to face all the challenges. Rather, the multi-sectoral approach, the caregivers, the family and friends and brothers and sisters and their initiation, they are much more significant and helpful for the mental health. And we come to a better understanding that how much important the mental health issues in the pandemic situation. You know very well that our country is a 170 million population, and we are facing the challenges remaining the MNCAs and MMR. And we have come to know a better understanding that in the COVID situation, those issues are very much addressed by the caregivers. And we have initiated some multi-sectoral whole of the society approach from the civil societies, from the non-benefits organization, and all the issues come from the different platforms they have initiated in the COVID pandemic. And we have the whole of the government and the society approach. And we have come to a better understanding that the MMR rate and the MNCA's progress is much more better than we have expected. So the role of caregivers, the recognized how to integrate them in the healthcare facilities, how to integrate them the process of medication, process of caring, and you know a better understanding that only medication are not sufficient. Only medication you are giving the patient the medicines and all those supports are not enough. Rather, being friend, they serve as a friend and family member is much more important. And that's why our Ministry of Health and Family Welfare have included the caregivers and the representative as a member of the infection and infection control national committee. And that was a very good understanding. And my insight is that to have a better understand how the caregivers can be included in the healthcare system, how their roles and engagement and what support they need are much more important to facilitate the whole of the society approach. And we have a better understanding also that their training and capacity building are very much helpful to benefit, to maximize the outcomes of the patients. So how to integrate all those initiatives from the non-governmental platform as much more important, and caregiver is growing a much more significant and important platform in the healthcare system. So far, I come to understand.
Thank you. And so, Dr. Garg, India has really lead the way in family-centered care. How do you think training and supporting family caregivers can play an active role in further achieving the SDGs? I mean, we talked a little bit about the undue impact on women, the even economic impact it can have. And what do you think others could learn from some of the work that you've been doing in India on this issue?
Thank you very much. I would like to start with saying that, as His Excellency Honorable Minister of Health Indonesia mentioned in the beginning, the most important role, the most important realization that the health systems across the world have had is that preventive and promotive care is definitely more important than curative. So in India also, we've seen that our move towards achieving the SDGs has happened more faster or in an accelerated way, since the approach from facility-based or tertiary-based care has moved to primary-based care or community-based care. And from communities, I think it's very organic that the next step would be going to the families, where the caregivers are a big support system to any person who's suffering from a disease. And also in India, and also other countries with similar social constructs, families have anyway been the traditional caregivers. They've been the ones caring for people who've fallen sick. So it is only using a resource, giving them the adequate training and support that is going to help us in, of course, achieving SDG 3, which is for health and well-being. And the role becomes more important where the disorders or the diseases require minimal intervention, but more of adherence to established protocols that need self-regulation, so that there's someone who can discipline, someone who can support. So NCDs, reduction in premature deaths due to NCDs, is one major SDG where we see that the caregivers would have an important role to play. And of course, achieving targets for maternal and child health is another one. As mentioned, there's nobody like a mother who can take care of a newborn. And reduction in, as mentioned in the morning, reduction in newborn readmission rates has drastically reduced with the caregiver approach. So, but not only SDG 3, but also when we talk about women. So we were having a meeting of stakeholders for working on a strategy for autism. And we had a meeting with the family members. And the question was, where are the fathers? They were all mothers. And it is not that the fathers don't want to be there. It's just that social constructs are such that when faced with a stressor, the automatic response of a family is that the mother goes out of the economic system and the father takes care of that and the mother takes care of the family. So I think that in reducing gender inequality, of course, it has a huge role to play because it provides it gives a balance to the caregivers, both male and female, to be able to do both the things at the same time. Then again, SDG 10, reducing inequalities. If we're able to bring healthcare to people at their homes, then the difference between haves and have-nots, of course, reduces. So I think caregivers have a huge role to play across SDGs, not just for health and well-being. Then coming to what can be learned from the Indian model. So India itself learns from India. We are such a diverse country. We have different states. And also for the companion caregiver model, we've had different models being followed across our different provinces. So depending on the disease burden there, depending on the particular needs, there are very various models which have been very successful. Evaluations have shown good results. So, and at the national level, we have also been learning from these systems. We now have a caregiver model for tuberculosis at the national level. So we are here to help anyone who wants to learn, to share our models, and at the same time to learn from others what we can do more and how we can take this further. Thank you.
Thank you. So, Dr. Syed, you head up policy and partnerships at WHO's special program on primary health care. How do you see the role of caregivers fitting into the broader primary health care system and approach?
So much, Kate, for that question. So first of all, just listening to all of the distinguished panel, there are so many different points that indicate the need for a primary healthcare oriented health system. Mm-hmm. And fundamental to that is, of course, point of care issues and clinical care, but also, and many colleagues in the room will know, the three core components of primary healthcare approach. So services, the engagement and empowerment, and the multisectorality. So within that context, we can see the power of family caregivers. But the health system, as colleagues have indicated, has a ways to go to be able to support those family caregivers in what they need to do. Second point that also may be highlighted is the critical importance of quality of care, whether that be quality of care delivered in a health facility, but importantly, the quality of care that's delivered in a household. And of course, as all of us know, health is produced in households. Health is not produced in facilities. And this is where the power of family caregivers really comes in. And then the third point really also points to the introduction that Edith and Shahid put forward, is you'll notice that they were talking about love, and deliberately so, I think. There's something there in terms of compassion that needs to drive the future health systems. And when we talk about compassion, we can talk about it loosely, or we can get into the nitty-gritties of what compassion means within the context of a health system. So the concept of being aware of human suffering, the concept of empathizing with that suffering, but importantly, not just leaving it at the empathy, but taking action to alleviate that suffering. And examples from family caregivers, I think, are some of the most powerful examples of where compassion is being delivered from one heart to another.
Yeah, and that can be so hard to quantify and maybe, even hard to scale. And so, His Excellency, I would love to hear how you think about some of these challenges in Indonesia and some of the opportunities when it comes to supporting caregivers, whether it be through training, whether it be through financial support, and how you think this can better enable a more compassionate and more effective overall healthcare system. Let's go ahead and.
I became a Minister of Health on December 2020, just at the beginning of the COVID. So the first time I read about SDG 3 is on June 2021. And I still remember that. My apology. Again, I'm a banker for 30 years. To promote healthy life and well-being for all people and all ages. What the thing I noticed? There is no such a statement called to cure sick people. And then I had my first G20 health ministers meeting in Italy. I think August 2021. I shake hands with 20 health ministers of Italy, health minister of Brazil, health minister of United States. I'm looking for a health minister with the title Minister of Sickness or Minister of Cure. I couldn't find any. So the point is, our job in the healthcare sector is to keep people healthy, right? Because it's mentioned in SDG, and also no health ministers have a title Minister of Sickness or Ministers of Cure. And that is what I would like to propose to caregivers. It's not only handling the sick people, of handling after sickness, but your focus should be to keep your family healthy. And now we would like to do it in Indonesia. Indonesia, number one killer is stroke, 300,000 per year. No, that is the registered number. Actual numbers you multiply by 3. We are very bad in registering. Number 2, heart disease, 250,000 per year. So I started with this one as an engineer. Let's prioritize in those two. Stroke, this is cardiovascular disease. You just measure the blood pressure. Now, you have to go to the district level, 10,000 puskesmas. Now I'm thinking, how can I distribute, the blood pressure, devices to all 68 million households? It's not that difficult, to measure. If about 130 and 90, then the mother should push the husband to go to the puskesmas and get a free amlodipine. Second is about glucose. Diabetes in Indonesia is growing like this. That is also the cause of stroke and heart disease. What we are doing now, you have to go to puskesmas, measure the HbA1c. If it's above 5.7, then you have to take metformin. Now we are thinking if we can send a POCT to every household, every mother, so can stuck the needle to the husband, scream a little bit, take the measure. If the glucose level is about 200, you get a free metformin in the Puskesmas. The third one is about the blood lipid. Now you have to go to the Puskesmas, measure your LDL level is about 100, then you will take it, the statin, atorvastatin or simvastatin or whatever statin the doctors will prescribe to you. But now we are thinking, can we have a POCT that give it to the wife, and the wife can stuck again the needle to the fingers of the husband and measure whether the total cholesterol level is about 200 and send it to Puskesmas and ask for the statin. And we need to change the lifestyle of the family. Only the wife can scare the husband and scare the family. Hey, you cannot eat more rice. Your waist is above 90 centimeters. Your jeans is above 32. Otherwise, I will not give you any rice. And by the hell, you have to run every day, 30 minutes, every day, 5 days in a week, because that is a WHO standard until you die. So only the wife can do it. So that is what we are going to do in Indonesia.
Well, I imagine there are probably a few wives who wouldn't mind sticking their husbands with some needles, but I'll digress there. At our last moments together, I would love to hear from each of you just one recommendation you have for our audience, one thing you would like to see them take action on or think about as it comes to supporting family caregivers. And we'll start at the end with you, Dr. Syed.
Perhaps the one action is when we're thinking about family caregivers, let's think about that as part of a health system that is oriented towards primary health care and with compassion at the heart of that.
Dr. Gag?
I think that it's time that we realize that family caregivers are the backbone of the health system, and that is how it's going to be in the future, and we need to start working for that.
So thank you very much. You know very well that the Sheikh Hasina initiative for community clinic in Bangladesh, and there is a very great opportunity to engage the family caregivers to the community. You think of a pregnant mother in the heat waves running in the Southeast Asia, especially in the Bangladesh, and how much support requires a pregnant mother from the caregivers, his family or her family, husbands, as the Honorable Minister, His Excellency Indonesian Health Minister was telling. That is much more important. So it is time to recognize the family caregivers in the healthcare processes, healthcare facilities, so that they could come to a better understanding with the families, with the patients, and the community. That will be much more helpful. And another thing is important, how to engage themselves, what levels of family caregivers to engage in the healthcare processes. That is good. That is very much important. And the nature of the teamwork in ways they are supposed to do, in which they are supposed to deliver the optimum outputs of the patient outcomes. That's are very much important. And the capacity building of the family caregivers, the patients and their family members are much more significant and important. So I think that these records, the policy support with the governmental platform, with the civil society platform and all other people, those who are engaged in the healthcare facilities, in the healthcare process. That is much more important. Thank you.
Thank you. Dr. Banerjee?
I was just thinking of innovation. So we know that when women are pregnant, they should have antenatal care. And so one of the innovations that was brought in was around group antenatal care, group ANC, whereby some of the messages and interventions that can be done in a group are provided to the group. But then the innovation that came out of that was that those group of future mothers would actually be a support group for during the antenatal care period, but also afterwards when the babies were born, and they supported each other in ensuring the child would come for immunization, etc. So I think support groups would really be important for in order to support caregiving, so that they can support each other. They know what their issues are, and they can step in when someone else is not able to do so, or remind each other of what needs to be done.
Excellent. Your Excellency?
I've been a CEO of the largest bank in the country for 30 years, managing the money and the wealth of my clients. I've been 3 years as a Minister of Health, managing the health of my people. Trust me, the best wealth is health. Thank you.
Well, thank you to our esteemed panel. Thank you to Nora Health. I know we have several team members from Nora Health here. If you want to talk with them in one of the breaks later, I know they also have some goodies going around. But thank you all very much. We will now continue the conversation looking at the future of Gavi, and I would like to introduce my colleague Ruby Chikamba to the stage.
Thank you so much. I think we can all agree that was such an interesting panel. And as we make the transition, I'm just going to call some of my panelists to come on stage. I have Dr. Sanya Nishta, who is the CEO of Gavi, the Vaccine Alliance. We have stairs this way, Dr. Nishta. And Professor Muhammad Ali Pate, who is the Coordinating Minister of Health and Social Welfare in Nigeria, as well as Javier Guzman, who is the Director of Global Health Policy at CGD. You don't have to push the mic on as soon as you start talking or just for, yeah. A star-studded panel that we have here, and really excited to have all of you here. So I have had the privilege of reading an opinion piece that Dr. Nishta has just written for Devex. It's going to publish later on our site later today. And just plugging that if you guys want to get that delivered into your inbox, I suggest you sign up for Devex Newswire, which is our daily newsletter if you haven't already. So Dr. Nishta, it's been 2 months since you started the role as CEO of Gavi, the Vaccine Alliance. So we're really honored to have you here with us today to share some of your insights as you get into this. And in addition to the change of leadership at Gavi, you guys are also set to introduce a new strategy. I just wanted to check with you, 2 months down the line, how do you foresee Gavi changing within the next couple of years?
Well, thank you for the invitation. Thank you very much for the invitation to be on this very exciting series of interviews that you're conducting this week. Devex is a very important communication partner for us, and thank you for your question. So as you know, Gavi is currently in the process of revising its strategy. The strategy which will commence January 2026 for a 5-year period. We call it Strategy 6.0, and there are a number of important changes within that framework. And alongside, we are also kicking off a process to fundraise, which is called replenishment for the same period of time. In terms of your question of what changes we should expect, so let me share my perspective with you. As an incoming CEO, 9 weeks into the role, I see that there's a landscape where the institution has done remarkably well over the last 24 years. It has vaccinated 1 billion children, saved 17 million lives, contributed to halving child mortality. And it operates at a very low cost. It's a very efficient model. There's a clear path to sustainability. Countries graduate, 19 countries have graduated, countries co-pay. The model is also very resilient and agile. It came into play during COVID. And now, as a result of catalyzing the ecosystem, we have a number of different vaccines, about 20 vaccines. For most of them, there is no supply constraint. So for a new CEO who's grounded in country work, in developing country work, I see an organization which is fairly well running. I see 20 vaccines on the market. I see that for most of them, there's no supply constraint. But I also see the challenge. The challenge is delivering it to the last mile. The challenge is navigating health systems in countries. The challenge is reaching zero-dose children, as they call them in the Gavi parlance. These are millions of children who have never been immunized. So my focus would very much be on bringing innovations to scale to overcome the systems constraints that exist in countries. My focus would be very much on simplifying the grant making process, making the country at the heart of decision making, and I'm sure my brother Mohammed will have a lot to share in that respect. This My focus would be on empowering the countries, respecting community voices, putting countries at the heart of decision making, coordinating better with other global actors in the global ecosystem to support ministers like Mohammed. My focus would be very much on other than the country facing work and execution, would also be forward looking. What do we see 20 years, 30 years, 50 years from now in terms of the vaccination landscape, and what we can actually do to catalyze changes which will enable us to bear the fruits of science and innovation in ways that empower people and in ways that save lives in the most underprivileged populations. Um, my focus also would be on women. I'm just coming up with my 6-month plan, and one of the 5 important pillars is a focus on women, both secretariat facing, both country facing, and then of course my focus would be on, given that we are in an environment where conflicts, climate change, and all these fragile situations are now the norm. They are the new normal. So my focus also would be very much to position the organization to serve those situations better, and not just for conflict and climate change related matters, but also for outbreaks and epidemiological emergencies. So across these different domains, I've already initialized work, and I'll be releasing my 6-month plan soon, where areas, milestones, timelines are all articulated. So exciting time.
A very exciting time, and we're looking forward to reading that 6-month plan and digging into it. You've said a lot of things that I want to unpack in this conversation, but one thing that you keep stressing is having countries at the heart of decision making. And Professor Pate, I think you can definitely speak to that. What do you want to see from Gavi from a country perspective?
I think I'll say we want to see a lot. That answers your question. Gavi has been one of the most successful public health partnerships we've seen in the last 25 years. The miracle of vaccine, it has been able to take it further than any other partnership that exists in terms of getting children vaccinated. A big kudos to all the excellent staff of Gavi and the new CEO that is setting up a very ambitious agenda, which we're looking forward to. But it's 25 years or so in the making. And I think many things have sort of shifted, and I think there is an opportunity to rethink the model of the alliance in terms of eligibility, in terms of transition, in terms of the country alliance functioning. I mean, the alliance functioning at the country level, how it shows up. This is not necessarily only exclusive to Gavi, but it's to global health initiatives broadly. If you are at the country level, what you see is a cacophony of global health partnerships that are fragmented. The global health landscape is hyper-fragmented. The coherence is lacking, and the transactions are multiple. So to what extent does an alliance like Gavi and others come together and actually work, make it easier, put countries at the center and reorganize backwards? Country contexts differ. One solution constructed in Geneva doesn't apply in all countries equally. So I'm very glad that the new CEO of Gavi was able to visit us, to go to the field, to see the realities in our country, and we really appreciated that visit to understand, even within a large country like Nigeria, that differences, significant differences between Sokoto, which is a very low-income country sort of context, and let's say a state like Lagos, which you can say is a middle-income country. Those differences actually matter. So
really flipping the model to think of countries at the center, organizing yourselves from the global health initiatives in a way that supports country priorities, using national systems, because these are the systems that have the reach, the legitimacy, and in fact can be more sustainable, and thinking about other elements of fiscal policy that is necessary to sustain whatever it is that is introduced. Gavi has been able to reduce the cost of vaccines to make them accessible. Amazing feat. I think we need to see more of that. But when you look at the model of, okay, introduce vaccines over time, then you ease out of it. Well, you pile on these vaccines. Countries have to be able to afford them. And how do you really work as an alliance? Not necessarily just a secretariat. I'm calling out all the members of the alliance, WHO, UNICEF, World Bank, all the various parties to come together around country plans, use national systems, have some humility to understand country context, and support in the delivery of vaccines. And I'm really glad that Dr. Nishtar, my sister, is working in that direction to put countries at the center of our agenda. So.
Dr. Pate really outlining there what countries would want from Gavi. And like he said, it's a lot. But also, Javier, CGD also published a policy paper, which is entitled A New Playbook for Gavi. And I think it incorporates some of the things that Professor Pate has mentioned. But what more do you want to see out of Gavi?
Thank you. Thanks for the invitation. And just wanted to say this is a crucial moment for Gavi and for other global health initiatives. And we need to recognize some trends and we need to recognize some disruptions. So in terms of the trends, I think it's important to acknowledge that the macroeconomic climate is not ideal. And it's not ideal for Gavi or for global health in general. And it's not ideal for countries. So domestic financing is also difficult. And that has to be part of the conversation. The second thing in terms of the trends is something that we've heard. I mean, we all recognize the importance of localizing. And localizing implies decision-making by countries, implies regional manufacturing, implies changing the model of decisions in Geneva, and that's just not going to be easy. And last but not least, in terms of the trends, Dr. Pate mentioned the importance of the future in terms of reducing fragmentation. So if we think about 2030 and the Sustainable Development Goals, there needs to be a new playbook in terms of what's the future going to be like. It cannot be vertical. It needs to be integrated. And the future of global health initiatives, the implementation of the Lusaka agenda, I mean, that's all going to be part of the conversation as part of the replenishment and the new strategic period. But I want to also mention 3 disruptions that are very important in terms of the status quo. First is, Dr. Nishta said, zero-dose children. Those children that have never been immunized are actually increasingly in middle-income countries, the countries that are no longer eligible under Gavi. So that is a very big issue. I mean, discussing about eligibility and discussing about middle-income countries and how to reach those children. The second is conflict and fragility is no longer an anomaly. It's actually the norm. Nearly 50% of the countries eligible currently under Gavi are classified as fragile or in conflict. So the same model that Gavi has applied in the past is not going to work in the future for those countries. And this is very important. And last but not least, this is something positive. We see a lot of interesting good vaccines in the pipeline. We're now talking about TB. We're now talking about 2 malaria vaccines. And that basically means, well, of course, promise, but also challenges. So I'll stop there. Thank you.
So much to unpack, Dr. Nishta. I think we've got 100 million questions from you coming from there. First of all, I want to talk about the current climate. Javier is talking about finances and how they are constrained. In addition to that, we talk about conflict settings, how this is the new norm. And then we also go into eligibility and how so many of the children that you want to target are in countries that are not eligible for Gavi support. So do you see all these things being incorporated in Gavi 6.0 in the new strategy? And how are you working to sort of counter some of these challenges that both Dr. Pate and Javier have highlighted?
Well, I think both Mohammed and Javier make very important points. As far as the middle income countries is concerned, and the middle income country have a specific definition in Gavi. These are countries who fall above the eligibility threshold, but are still below another threshold. And these are either never Gavi, or these are former Gavi countries that have graduated. But these are countries where averages are hiding a lot of inequities, let's put it that way. So and some of these are very large countries where majority of the zero-dose children sit. There are also some countries who are on the path to graduation, either in the preparatory phase or in the accelerated phase. And Nigeria is a case in point, where averages again hide a lot of inequities and where there are pockets where a lot of zero-dose children sit. And I went, Mohammed took me to Sokoto in the north of Nigeria, which presents one such illustration. So a long-winded way of saying, yes, this definition of mix is very much within the purview of 6.0. And there are specific policy levers which will allow us to be responsive to these pockets. Also, triangulating mix with fragile contexts, and I completely agree with you, this is now the new norm. These are not these isolated pockets that sit here and there. So again, there will be flexibilities and tailored approaches allowing us to respond to these situations. And the other thing you talked about, your first comment was about what country empowerment means. And you very rightly said that country empowerment is not just, it should not be notional. You have to back it with a concrete set of norms and principles and execution mechanisms that truly localize decision making, that have to do with attention to domestic capability to co-finance, that has to do with empowerment of regional manufacturing. And I couldn't agree with you more. And I can tell you that both Strategy 6.0, as well as my set of priorities articulated for the 6 months, will be grounded in these realities. We have no other option from a model standpoint, from a practical standpoint, but to empower countries. That is the only way to make things happen. And in order to do that, there are two sets of imperatives. The first imperative is for us as global health entities. We need to coordinate better. I think this is the fourth panel that I'm going to over the last 48 hours, where I'm saying the same thing again, which is to draw back on my experience as a minister of social protection, where the largest department I had was the department that coordinated with all the donors, the multilaterals and the bilaterals, different reporting lines, different procurement systems, different asks, different frameworks. And for a significant period of the time, I used to be following those. We need to change that. The donors need to, the donor partners need to act with one line of support. And there's a lot of convergence that has to happen between us, between Gavi and the Global Fund to begin with, which is something I'm taking very seriously. But then also, and I think Mohammed will understand that because he is a federal minister in a large federating country. So he will know exactly when I say that country empowerment also has to do with an in-country agenda. Because a lot of times, external agencies feel constrained because the federal government doesn't want to pass powers to the provincial or the state government, and the state government is not relinquishing control in favor of the local governments. So if we really have to meaningfully, if we're really and meaningfully interested in impacting the poor woman at the last mile, the poor child at the last mile, if we're really and genuinely interested in their welfare and their well-being, we have to do things differently. You might want to call it a playbook. I might want to call it something else, but we have to do things differently. We have to coordinate better at the global level and let go of our egos and turf issues and controls and budget pockets and think in the interest of people on the ground. And then, of course, the country has to do likewise. So I don't want us to think that the problem lies at the global level only. I think the countries also have to get their act together. A lot of countries will not will not localize power, money, and resources, which is where that needs to happen. So there's a change that has to happen in both directions.
Thank you so much. I want to talk a little bit more about country ownership with you, Professor Pate. But before I get into that, one thing that was brought up, and Javier, you mentioned this, is this regional and global balance in vaccine manufacturing and procurement. To both of you, Professor Pate and Javier, and I'll start with you, Professor Pate, what role do you see Gavi playing in changing this landscape?
An important role, because beyond the funding, the grant finance, the vaccines that it supplies, an important role that Gavi does is the market shaping the vaccine industry. And it can use that to decentralize manufacturing capacity, and it is already doing that with AVMA. We just hope that it will go further than financing vaccines that are filled and finished in the continent, but that the real manufacturing begins to take hold. And there are other things in the back end in terms of regulatory capacity, talent building, other support that either Gavi as an alliance or other partners that have a shared understanding of this challenge will help countries decentralize the capability to produce high quality vaccines. That will be an important shift that we'll be looking forward to seeing. If you want me to talk about the country ownership, I can also go on that path. I think building on what Sanya also mentioned, those of us from poorer countries, yes, we're poor, but we also have sovereignty. And we want that sovereignty to be respected. And we want the lines of accountability to be shifted in a way that is sort of much more balanced, so that the prioritization, the choices that are not made on our behalf above us, but with us and responding to us and our needs, and be held accountable as well. That is a major shift that needs to happen if we look at where we are after 25 years of the global health initiatives. I think that's something that will just buttress this idea of country ownership that respects the sovereignty and sovereign decisions of countries and puts a locus of accountability on the people that are being served, not only those who are providing the resources. Yes, we appreciate, but at the same time, that sovereignty of countries has to be respected.
So I have a follow-up question to that, which is a $1 million question, I think, but I'll come back to you, Professor Pate. You might know what I want to ask. But I'm going to jump to you, Javier. When we're talking about this vaccine manufacturing, what role do you see Gavi playing in that?
You know, as Mohammed said, AFMA is, a 1 billion advanced market commitment to incentivize manufacturing. But I've got two things to say on that. The first thing is, unfortunately, Gavi cannot limit itself to just financing because it will fail. And therefore, that basically means leading a coalition of the willing to make this enabling environment a success. And that's not going to be easy. If you look at regulation, for instance, out of the 14 countries where you've got manufacturing projects now, only 2 are actually eligible for pre-qualification. 12 are not eligible for pre-qualification. Basically, that means that if the requirement is to have a pre-qualified product, only 2 out of the 14 are able to get that. So you need to work on alternative pathways. You need to work on regulation. You need to work on enabling environment. And I'm not even talking about, last mile delivery. So that's the first thing. So coalition of the willing. But the second thing is we see Gavi, of course, leading on what they know, but we see how the landscape is very fragmented and is very uncoordinated. A lot of people are actually investing into local manufacturing without actually agreeing how this should be done and agreeing on a coordinated effort. I think that's key for this window of opportunity to materialize, because we should not fool ourselves. We've been here before. This conversation about local manufacturing and increasing resilience and increasing is coming from the past. Of course, COVID was a wake-up call, but we cannot go ahead without really seizing the window of opportunity.
Thank you so much. That's really important to highlight, especially at this time with WHA 77 and the talks that we just had about the pandemic treaty and how we are a little bit stalled to remember this is a window of opportunity. But Dr. Pate, I want to go back to you because I'll be remiss to let you come off this panel without asking this question. So you talked about country sovereignty, and I think from all the conversations that I've listened to or all the things that I've read about things that you've said, you talk a lot about country ownership and working within the national health systems that already exist and how important that is. And you're in a unique position for this panel because you were announced the CEO of Gavi and you decided to take on the role in Nigeria. May I ask why is that, and is this linked is this linked to this call for a sort of a focus on like a national plan?
I think it was to give way to a better CEO to Gavi. So, and Gavi has a fantastic CEO. I think Gavi has a fantastic CEO, so I'm really glad that we can work with her as well. I think it's, at the end of the day, for countries, I don't think the ownership, the respect will be granted to us by default. We also have to work to earn it. So going back to Nigeria, in a way, is in Gavi's interest because we account for a large part of Gavi's challenges, large part of many of the global health challenges. And we see that if we can get that sorted out with the president's focus on health and within the continent of Africa, I think it will make a big difference in terms of the balance and our ability to negotiate on the global stage. So I think it was a great opportunity to go back and continue doing the work that I think is important even for Gavi. That's why we're very glad that Sanya visited us immediately she started, and we look forward to a very strong partnership with Gavi in the years ahead. Yeah.
I think that's really important to highlight that there's work that's needed on both sides. And we're coming to the last 3 minutes of this panel. And I think one thing that we all agree on is that there's a need for things to change. It's a new environment. Gavi's done well so far, but there's a need for things to change. So in the last few minutes, I just want to get a few takeaways from each one of you. What do you want people to walk out of this room with? Javier, I'll start with you.
I think I would say this is a very important moment, and Gavi should treat this strategic period as a period of experimentation. From now to 2030, what are the changes that will need to be scaled up after 2030? Because we understand this cannot be changed overnight, but you need to put in place the mechanisms and the pilots and the changes that you will want to see in a big way after 2030. So I would finish with treating 6.0 as a period of experimentation where you can actually move on this big agenda of reform.
Thank you so much. Looking ahead, and Professor Pate, what would you like people to walk out of this room with?
Shift your locus of decision-making more towards countries. I think that's going to be very important. Adapt to our context, respect our sovereignty. I think organize better, show up more coherently, build national systems that are more sustainable, go deeper on the delivery. So several asks, we do have them, yeah.
Thank you so much. And Dr. Nishta?
Well, rather than summary points, I've got 1 minute 55 seconds, and I thought I would use this time to perhaps connect back to the sovereignty piece that Mohammed talked about. I couldn't agree with him more. And perhaps clarify a few points with regard to regional manufacturing that has been mentioned several times. So Gavi is launching what is called the African Vaccine Manufacturing Accelerator. The official launch is on June the 20th in Paris. But we need to be clear on what it will take to move towards the goal of vaccine sovereignty for Africa. It's a goal that we should all pursue. But we have to be very clear on what the path is to achieve that goal. And on that path, Gavi is one of the several players. I do not want anyone to believe that we have a magic wand and this is something that is totally within our purview, because it is not. We are one of the enablers. We may have come forward as a catalyst with a bargaining chip as a catalyst to say, yes, when everything gets up and running, we will underwrite with a subsidy of 1 billion when it comes to procurements, and we are signaling it to the market that yes, this will work at our end, but our role is just one in a very long chain. So 20 seconds to go. I want to explain what that chain is. Well, first of all, manufacturers, and there are some manufacturers in the room, have to set up the plants. And in order to set up those plants, there are a number of different things that come into play. Foremost, the government's policy. I mean, where do interest rates stand, for instance? That's nowhere in the conversation. I mean, a market actor is going to look at an enabling policy environment, and interest rates are going to factor into that in a major way. What is the government's policy on manufacturers? Are they going to give any subsidy? Are they going to give any tax breaks? What is the government's overall policy environment like? Does that country have chemical industry? Will they be sovereign when they're just doing fill and finish? And when there's no chemical industry or capacity to produce active APIs on the continent? And are the countries willing to share active APIs or not? So that's another consideration. What about the regulatory capacity? What about the human resource? What about diagnostics and lab capacity? Because from our experience in other countries, we know that it takes decades to build that capacity. Once, of course, the plants are there, then the question of demand comes in. So if you have plants already in Africa, and if African governments are still procuring from the West, then that defeats the purpose. So getting the plants up and running, getting them to produce quality products, getting them to get them pre-qualified from their, getting them passed from their own regulatory agencies, getting the vaccines PQ'd by WHO, then pulling in the demand, then for them to compete in tenders, and that's when our role comes in. So I do not want anyone to think that Gavi has the money to put into the plants, or that we are the ones who will do everything in the country. We have a defined role, or we will play it very well. We've already set aside the money. We have already gotten the initiative approved from our governing bodies. We have, in fact, July the 6th, our governing body will be approving the final structure of AVMA. The money is in the bank. We are ready to come in, but the manufacturing capacity has to be set up. The vaccine has to be PQ'd. They have to compete in tenders, and governments within Africa have to have an appetite to procure from their own plants, and that is how this ecosystem will work.
Thank you so much, Dr. Nishta. And Professor Pate, I know you want to respond to that, so I'll give you 1 minute. I'll give you 1 minute.
2 seconds. I will say this, the old model, the way things have happened over the last 20 years. But there are things that are shifting. Technology for vaccine manufacturing is shifting from biologicals to chemistry. And we can leapfrog. And for Gavi, the question is whether it's the old or whether it's willing to go with the new. Because so long as Gavi goes on the path of a concentrated supply from 1 or 2 areas, traditionally, it may begin to lose countries as they become more prosperous and the vaccine manufacturing capabilities are decentralized. They'll find a way. So that's a very pivotal moment, and an ecosystem approach is needed, and governments need to rise up to do what they need to do. And that's why in the case of Nigeria and also the Africa region is really intently looking at that, because the world before COVID was certainly not working very well for us. And we don't want to rebuild that world. What does the new world look like? And so the litany of things that we have to do, that's traditional. But I think we're keen to look at how we can disrupt that. And we've seen that in other regions, how that has been disrupted. So we're one of the first regions to diversify our manufacturing capacity. So I think it's a big question for us at the country level, but also for the global health ecosystem and actors. Are we going to be held back to be coming back to Geneva for our vaccines? Or are we going to have a system whereby the global pools can buy from us and develop with us as well as part of this global commerce in preparation for whatever it is that comes next in the pandemic? Thank you.
Thank you so much. We have unfortunately run out of time. I had more questions, and I'm sure our audience had more questions as well. But we will continue this conversation. Please sign up for Devex CheckUp. This is one of the topics that we follow quite closely. Thank you so much.
Thank you. We are going to continue the program. And I know Roombi was plugging Devex CheckUp. I also want to make sure you're aware we have a Devex podcast that we're recording some special edition episodes of here this week at WHA. So make sure you also subscribe to that podcast. We are going to continue the conversation. So ask if everyone could please either sit down or quietly exit the room. And I'd like to invite my colleague, Ali Blunt, to the stage for our next session with Evolution on Healthy Aging. Thank you, Ali.
I know that's a bit of a tough act to follow, but if everyone could take their seats, I'm really excited to be here for the next session. All right. Good morning, everyone. Please help me to welcome to the stage our next speaker, Dr. Mahmood Khan of Evolution. Get cozy here.
Working?
Your microphone should be on.
It's on.
So
I think we're
yeah, I think we're in the middle of a post Gavi exodus, but we'll try to keep the energy up. So let's go ahead and get started, Dr. Mahmood. So the 20th century saw a remarkable rise in lifespan, but not necessarily health span. So could you explain for our audience the implications of that shift, just to set the stage here?
Well, let me just to kick us off, look at this at a macro level and look at the implications of this. We've made dramatic progress. Vaccination was an important part of that. Fetal mortality, infant mortality has come down. HIV, all of these were contributing to, in a lot of part of the world, premature mortality. And so we've seen life expectancy around the world, on average, go up by 20 to 30 years over the last 50, 60 years. So that's been great progress, right? Life expectancy went from the late 40s, early 50s age group up into the 75 and in some countries 80. However, of that 30 years, we've seen about 20 years of that now accompanied by chronic disease. Whether it's cardiovascular, dementia, diabetes, cancers, all of these. Our health systems globally are not prepared in any country on the planet today to take care of that very substantial disease burden. Not in the United Kingdom, not in the US, not in Europe, let alone in low or middle income countries. So the implications of this are not just for ministers of health, but for ministers of finance who have to come up with the resources to support this dramatic increase in cost of healthcare.
Yeah, and can you talk a bit about some of the specific challenges associated with current healthcare models when it comes to active aging, particularly in low and middle income countries?
So we've clearly recognized for a long time that in any country, developed or otherwise, primary healthcare and preventive medicine is way lagging. One of my favorite statistics is in the United States, the support for schools of public health and primary care, adjusted for inflation, has been going down for the last 30 years. And yet, cost of medicine has continued to go up. So there's an uncoupling in preventive medicine anyway, and preventing age-related diseases, which now account in the developed world for up to 2/3 of healthcare costs, are actually what's lagging, and we do not have that ability. Our health system is an interventional model. You get sick, you go and engage with the health system. When you, quote, recover, you disengage. It is an episodic care. There's really not a life journey care. Aging cannot be addressed through episodic healthcare models. Unfortunately, much of the lower middle income countries have continued to emulate this developed country Western model of healthcare, which has built lots of hospitals, lots of cancer centers, lots of diagnostics, and when you're sick, we'll be able to take care of you.
Right. So what I'm hearing is current models are grounded in an intervention versus prevention model, and what we need to do is really start focusing on prevention. What strategies can countries around the world implement to effectively respond to an aging population to improve health span?
So let me start with 3 striking statistics that always remind me of why I'm working in this area. Today on the planet, there are more people over age 60 than under age 5. It's the first time in human history the world's population has more people above 60 than under the age of 5. Think of the implication of that over the next 20 or 30 years as the population continues to age and we have very few children to take their place, and support the care that that aging population needs. Second statistic, by 2050, the population of people over 60 is going to go from 1 billion on the planet today to 2 billion. The population is going to double. And the pyramid that we've been used to as we were growing through our schooling is now inverting. Some countries already has. So that's the challenge of doing. So what can be done about it? Number one, we have to think about our healthcare delivery models. We've already touched on that. Second, and I would refer, since we don't have a lot of time, to people, if you go to the US National Academy of Medicine's website, there is a global roadmap on aging that I had the privilege to be part of the commission that helped write that. I would ask you to look at it. It's a 250-page document that includes developing and developed country input, since it was a global roadmap. Some key areas, not only the usual lifestyle, environment, city design, infrastructure, all those things are touched on and are going to be critical. The other piece that there's less, but progress is being made, and I will come back to democratization in a minute, the technologies to diagnose aging and the technologies to change the biology of aging are no longer Star Trek future theoretical science. The science is actually progressing very rapidly. It is on the cusp. We have amazing publications that are now coming out of academic centers around the world saying this is not inevitable. However, what really scares me and worries me as a leader in the field is not will we solve the technical challenges of keeping our tissues and our bodies healthy for longer, not living longer. Let me be very clear. This is about staying healthy for as long as possible. Instead of 10 or 20 years of disease, how do we shrink that period? The challenge is how do you democratize those technologies to have impact globally? Because what we're seeing is the majority of people who will be over 60 are going to be in low and middle income countries. The economic impact is huge if you're successful. This has been done by Professor Andrew Scott, who's modeled the economics of this. However, the divide between the haves and have-nots, purely on GDP productivity, will only widen unless we can figure out how to scale these technologies and get them into the hands of the populations where the impact can be had.
Thank you. So It's, I believe, Evolution's first year here at WHA. I know you're keen to engage with this community of global health leaders that we have here. How do you envision engaging with stakeholders, both traditional healthcare sphere and outside of that, to support this shift that you'd like to make toward healthier aging?
If we think about the different sectors that need to embrace and understand and integrate this from a value chain, and I don't mean value chain from a product, but the value chain from science to delivery, we have a number of sectors, and we're engaging with all of them. Obviously, upstream, we need to understand the science, but even before that, we're actually engaging with communications, media, the public sector, because this is a field that it lends itself to be misunderstood. If you go to somebody and say that we're interested in healthy aging, they have visions of some expensive spa. My wife wants me to discover the next wrinkle cream. You name it, that is the image of healthy aging. We need to take that on. Secondly, there are what I call pseudoscience players in this space that are willing to sell hocus pocus. Right? We need to differentiate and build this on credible science. So media, communications is important. The science community is the engine to drive forward the inventions. We have Evolution are the second largest funder of aging biology and neuroscience in the world, second only to the US NIH. We actually provide more funding in neuroscience than the UK government, than the European Union. Very few people, other than the scientific community, are aware of that. As an example, last year we committed to $300 million of research funding across the world in the science of aging and the biology of aging. And we're now continuing to scale that up. So the scientific community. The third is we also recognize if you're going to bring science to the market, whether it's private sector or government, you cannot get it in the hands of consumers and patients until you bring the private sector in. You just heard it in vaccines. You need the private sector at the table. To enable that, you need capital. Both venture capital, but then also ultimately large-scale capital. We actually have our own venture capital fund where 100% of the profits of our fund go back into our foundation. That allows us to patiently invest in this science and bring it in and incubate companies or invest in companies, and we're already doing that. The fourth is to actually convene and get the policymakers at the table. Because, and by the way, the first people on our list of policymakers is not ministers of health. I know we're at the WHO. It's the ministers of finance. Unless you get this in the minds of ministers of finance, the ministers of health are forced to take whatever is given. And I'm a healthcare professional. Having been on the receiving end, I fully recognize that countries have to prioritize, and in that prioritization comes health. So finance ministers have to understand the GDP benefit, the business opportunities, all of those things for them to be willing to invest in this. We are friends of the ministries of health. We want the ministers of finance to understand that. So we're engaging with those. And finally, the regulator. Unlike cancer or diabetes, this is an area that is so new, there is no path to market. There's no such thing, there's not a single government that actually has a regulatory path to bring a drug or a diagnostic to market that can address aging. Not one. And unless we do that, then the private sector is not going to come to the table. So several areas, and we're engaged with all of these areas.
Right. Second biggest funder of healthy aging work in the world, you said. So
the neuroscience, we're specifically focusing our funding on the science side, on the biology of aging.
So if you're working on this topic or want to understand where your work sits in global health against this is your guy.
I just lead a team.
Well, find Dr. Mahmood and his team this week. So we don't have a lot of time left, but I just want to wrap up with kind of a final call to action, recognizing there may not be a silver bullet here. But I mean, you've talked about ministers of finance, right? Policymakers, these different stakeholders. What specific action or actions can these different groups take, individuals, business, policy, to contribute to this mission to achieve healthy longevity for all?
There are some countries that are taking action already. There are some countries that have either appointed or actually in the process of appointing ministers of aging, separate to ministers of health. So they're recognizing that this is a national imperative. Some countries, it's not rocket science. When 40% of your population are over the age of 60, you don't have enough young workers to take care of that 40%. South Korea is a good example. The second, birth rates have dramatically fallen. That's a good thing. And I'll give you the Middle East. The GCC, the birth rate used to be around 6. Everybody says it's a young population. The birth rate now is just under 2.2. Replacement rate is 2.17. Now governments are acting. So we can get into that whole bucket. The second call to action is to actually engage the scientific and healthcare community to make this an area of interest for young professionals to want to focus their brilliant minds on. 30 years ago, when I came out of medical school, now I'm aging myself 40 years ago, the specialty to be in was cardiology, oncology, diabetes. I happen to be an endocrinologist. Nobody thought about wanting to be in the specialty of aging. Well, when 40% of your population is over the age of 60, that's going to need a lot of healthcare professionals, not just physicians, who can take care of that population. For those of you from developing countries or lower middle income countries, you do not have the infrastructure to take care of that population. Building more nursing homes is not the answer. So copying what was done in the UK or North America or Europe is not the answer for the developing world, so to speak. What is the solution in an environment where it's a pay-forward system? The young population takes care of the previous generation. Let me leave you, since we're short of time, there's a significant gender bias with this. 2/3 of social care of the elderly is done by a woman globally. It's either the daughter or the daughter-in-law that takes care of the elderly parent. It's not the son, it's usually the spouse. And so what that has as implications is unpaid, unrecognized, and career limiting. So we really have to think about how this is going to be taken. And finally, migration from poor countries to wealthy countries might give you remittances, but the elderly people that got left behind in the village don't even have their own young people to take care of those elderly while the young population is away working. Migration not only into other countries, but migration from villages into urbanization means the elderly got left behind. Look at the demographics of what's happened in China. There's great statistics from, for example, the Chinese urban versus rural. This is playing across the world in Asia, India, South Asia, Africa. We have to be thinking about it now. That's the call of action, because we cannot wait. It's happening now.
Really strong final thought there. And you can take my job bang on time watching the clock. Thank you so much for joining us. And thank you to Evolution, our partners.
Thank you. Take care.
Hi, everyone. My name is Sarah Jervine. I'm a journalist with Devex, and we will now be talking about localization in the health space. And if I could be joined by the panelists, please, on stage. We will be speaking with Dr. Gitinji Gatahi, who is CEO of Amref Health Africa, Petro Terblanche, who's CEO of Afrigen Biologics, and which is host of the WHO's Messenger RNA Tech Transfer Hub, and Dr. Angela Choudhury, who is Chief Catalyst at Swasti. Thank you so much for joining us. So there is a lot of discussion in the development space around localization, but it does require a transfer of power, and that's not always an easy thing to do. So Dr. Gitinji, I'm wondering if you could talk a little bit about the pace of localization in the health space. Is it happening rapidly enough, and what can be done? What are the challenges standing in the way of that to ensure that it happens on a grander scale?
Thank you very much. And I just want to start off by stating that localization is not a single point of activity. It's not a switch on, switch off. It's like a multidimensional concept that starts off with recognition that the people who have the most challenges also know the solution to their challenges. And I think that's the first point to state, that even in looking at the title of this session, which is How Can Institutions Empower Communities, I'm always of the feeling that actually the power is in the communities. So we can empower communities. And I think I was so disturbed by that I actually looked at the Cambridge Dictionary and I was trying to understand what does empower mean. So I have a few, it's a kind of a dichotomy. On one side, the word empower may mean authorize, license, entitle, allow. So when you use the word empower communities, it gives us the impression that we are actually giving them a license to do something.
Right.
We are giving them authority to do something. We are licensing them to do something, which is actually not true. Though there is also a different interpretation of enabling people's power. So I think, but many of us may interpret it as if actually we empower communities by giving them a license to do something. And that's impossible because the communities actually are the ones who have the power. We only work with communities because they allow us to. Yeah. So, and we have just completed the conversation on the social participation resolution for WHA, which WHO started working on many years ago. We're involved in part of that work to say, how do you actually create structures and tools and platforms for communities to realize their power, not for you to empower them, but for them to get agency to exercise their power. Because communities are the ones that actually hand over the mandate to government to operate on their behalf. And that government then creates an environment for us as NGOs, as private sector, to operate, to help the community exercise its power. What then happens is that without information, without structures, without systems, the community then may not know how to exercise their power by getting agency. So our role is not to empower them, it's actually to support and to work with them for us to strengthen their agency. And I think the challenge now, back to the question of localization, is that many institutions see themselves as acting on behalf of communities, and that's not possible. You can never act on behalf of communities. What we do is we take the community voice and we amplify it. And I think what I have seen, and we had a conversation on this yesterday, is that this localization agenda is based on who has the decision-making power, who has the money, and therefore, the way we use that money, we use it in a licensure manner to communities rather than saying, actually, we are working on behalf of communities and therefore the communities must lead what we do. So how localization must be seen is not a legal structure of creating a local registration. It's actually about how close to the people, the communities, is decision-making power. It doesn't matter where you see it, where the money is, but how close the decision on how to use that money, how close it to the community, who has the power to decide the priorities of the community. That's the journey we have to work on, and maybe we'll discuss what the challenges are as we go along.
Right. Okay. Thank you. So it's linguistic issues, and we will be more careful with our titles moving forward.
No, at least I'm happy I'm not jumping off the stage today because the gender balance is really good. So that's why I'm smiling.
Okay, great.
So this same room a year ago. So thank you.
Okay, thank you. And Angela, turning to you, coming from more of an NGO platform, how within your work at your NGO, how do you work to meaningfully work with communities?
I want to start by echoing what Gitinji said. The title did disturb me, and then I thought it was really clever of Devex to put something like that, so it would turn him on and turn me on and say, hey, we have to make a point. Who are we empowering and who's empowering whom? So I thought it was clever because I think the room wants to know where this conversation is going. I mean, how can you come up with a title like that? But also, if you flip it, who are the institutions that we're talking about? I will answer you eventually, but I just want to start from the title itself. Communities are disparate. They're not homogeneous people. They're people who are either defined by their work or their gender, who they are, where they live, all of that stuff. And therefore, to say communities and put them in a like a black box and design stuff around them doesn't work. But how do we hear communities' voices when we are sitting in rooms like this and when we're in front of our laptops and all of that? Is through institutions, community institutions. And so I was thinking of, hey, there's a way where there's a how where community institutions empower the communities. Who's going to take the voice? if an institution doesn't mean, like Gitinji said, they have to be registered. But self-help groups are also institutions, groups that come together formally or informally are institutions. And they are the ones who actually empower the communities. You can hear their voices. They are amplified. You have evidence through these institutions. But are they, we don't invest enough in them. They're the most poorly invested institutions there are. And they're the ones we should be trusting, proximal leadership is the most powerful, but also the most powerless and most underinvested. And therefore, I come to the call of action right now to say that who's investing in these community institutions? Because they can't survive. They have their daily bread. They're also from communities, the daily livelihoods, but you also want to hear from them and not assume when I was just in a panel on innovation and I said, well, you don't just engage with community after you've already designed the solution. They become part of framing the problem to begin with, part of setting up what system they are part of and the system of systems. And then you design the solutions together. You implement the solution together. You monitor the solution together. So without these community institutions, the communities will not find a space to participate. And that's how institutions can power communities.
Thank you. And just bouncing off the Gavi panel that we recently had, there's a lot of discussion around regionalization of the manufacturing of pharmaceutical products. And Professor Petro, if you wouldn't mind talking a bit about some of the challenges around regional manufacturing and what the WHO Messenger RNA Tech Transfer Hub is doing.
Thank you, Sarah, and thank you for the invitation to be here. Maybe just if I can circle back to my two colleagues, as a research and development and technology organization, a private sector company, I think for us also is to have the commitment on understand how we engage with communities and that we give back to communities. But that's just a comment from me. So the challenge around regional manufacturing of vaccines or other medical countermeasures are huge. We talk about low and middle income countries very easily, but low and middle income countries is a very, very broad term. So if I may take you to my own continent, Africa. Africa probably pivots and provides the best definition for low income countries and middle income countries. They're all present on the continent. 55 nations, 1.4 billion people. And the baseline is we import 70% of the medicines we need. We import 95% of the critical diagnostics we need and medical devices. And we import 99% of the vaccines we need. So how do you, from that basis, empower a continent to have health security and to be able to supply for their own people? And that requires an ecosystem. From the last mile in reforming healthcare and the previous panel on the caregivers and the importance of caregivers, for me was an eye-opener. There are 700 million women on the continent, 400 million mothers. Imagine if we can train them and teach them to do basic healthcare. So the healthcare system, following that is regulatory systems. How do we ensure that the products that goes to our people are safe and effective? Following that is logistics and supply chain. How do we get these products to our people? Part of the ecosystem critical in the previous discussions with Gavi is local manufacturing or regional manufacturing. How do we empower and build the capacity not only for full finish, but for drug substance and drug product manufacturing on the continent? The important role of governments in that little ecosystem around manufacturing, policy-based evidence, government's leadership to create an enabling policy environment that will incentivize local manufacturing, skills development, financial support, and then instruments such as the Gavi AFMA instrument, which is one of many, many innovations and additions and enablers for the continent. But then take two steps back, foster a research and development environment, end to end. Research development and process development, not only product development, epidemiology, surveillance, evidence-based policy development, and prioritize in translational research the development of products that will address neglected diseases on the continent. The African continent has a double burden of disease. Chronic diseases, diseases of non-communicable and communicable disease. How do we prioritize the development of products that is relevant for the continent? So unless we put that whole ecosystem in place, the continent will not reach a point of health security and preparedness for the next pandemic, but more than so, also socioeconomic development. The poorest people on the globe lives in Africa. How do we make contribution to build an economic system that can also sustain and provide jobs to those people? So it is an ecosystem, a whole village that needs to be built. How does the WHO mRNA program contribute to that? We have a tiny bit of implementation. We are foot on the ground. We're implementing. We're building capacity and capabilities for a future relevant technology, mRNA technology, relevant for vaccine development, for therapeutics, but also for other environmental and crop protection. We're building a platform, and we're building it in a system which is an open access system. We will share that technology and that knowledge with 5 other partners on the African continent and 10 other partners in low middle income countries. Where are we? We've completed platform. We have done the scale up. We've locked the process. In September this year, we will start with full package transfer to our partners. In the next 2 years, the technology transfer will be initiated and completed. And we thank the support of many people in this room for supporting us for the last 3 years in a phenomenal journey.
Thank you. Now we're going to turn to a question from the audience. We'll be taking a question from Smriti Patel, who is the founder of the Global Mentoring Initiative and has been deeply involved in the localization of international development work. Thank you, Smriti.
Great, thank you very much. And great discussion, and thank you, Dr. Gintaji. You really put, I think, the finger on the buzz when you said empower, because these discussions are really happening. So for you and the relationships between international organizations and local organizations are key, right? Especially the donors. So in your view, what needs to be done to change that relationship, and how can the power be shifted? Because it is about power. And also thinking about local organizations, women-led organizations, because they particularly are resource constrained. And they are the ones, and you said earlier, right, doing the work. So, just a question on that, if you can, if you can answer that. Thank you.
May I go ahead? Yeah. The traditional charity model was built on this concept of communities who are disenfranchised, they have no dignity, and therefore we are going to help them. And I think that's where the origin of the development started from. People are going out and saying, even for us as an organization, our founders in 1957 started by flying doctors to the rural areas on a camp basis, treating, flying out, flying in, flying out. So this is the origin of this work we're doing. But I think over time, we have to realize that communities is where the power is based. Now, that shift needs us to shift our mindset to say that for us to actually make that shift, we have to give up our power. And I think that is the difficulty of localization. Giving up power makes us feel vulnerable, makes us feel uncomfortable. And I will give an example. In the previous session, Sarah, I wanted to raise up my hand and ask a question to the Gavi CEO, but it ended too quickly. And the question, I whispered the question to her as she left, and I said, we have made an extremely important decision as Gavi to launch and to invest in the Africa Vaccine Manufacturing Accelerator. True? 1.5 billion, I think. Then we are launching it in Paris.
Right.
Isn't it?
Right.
Yeah? And I asked her, she whispered, said, oh, I wish I could change it. But that tells you that we don't give us power. That actually France, which is, and I'm sure there are French people here, so I'm sorry. I'm really, really, really sorry. Yeah? France, which is actually a great funder of Gavi and others, saw it fit to say, oh, now let us actually launch this fantastic Africa project here in Paris for Africa. That's actually what we have to remember, that we are trying to keep our power. I always say that the best way to serve the community and serve people, and I'm a member of the community, we are all members of community. So when we look at community, it's not those people versus us. Each of us is community. And the best way to serve our communities is to hand over our power to the communities. And we are unable to do that because of barriers. And those barriers have to do with money, who is going to control our money. Secondly, it is our belief of what knowledge matters. What knowledge matters to the decision making and to the power shift is we think we already have formed in our minds what structure of knowledge matters. And unless it's published in the Lancet, it doesn't matter. Unless it's published in the BMJ, it doesn't matter. So the communities don't know the BMJ, the communities don't know the Lancet, they have no idea. But they have knowledge that we don't publish. So we think that unless it's published, it doesn't matter. This is why when we are writing grants, by the way, AMREF is funded largely by earmarked money from the donors. So we appreciate them. And we keep saying that the fact that we want the community knowledge to be used doesn't mean that the donors don't matter. It's President Kagame who said, the fact that we do it ourselves doesn't mean we do it alone. So that's an important shift, that doing it ourselves doesn't mean we do it alone. So we're just saying, respect community knowledge, respect the system the community has, and find a way of using them. Don't want the community to have the same system as the systems of the people you're using in the past. Understand what knowledge the community has, what systems they have, and then say, how can we actually maintain accountability by using the existing systems? How can we rejig our systems to recognize that those systems will be different from the ones that are traditional? Then we can now shift our power, our accountability systems to reflect the community knowledge. So it's a major mind shift first before we can actually implement localization.
Thank you. Now, turning to Angela, so you sit on the steering committee of the WHO's Civil Society Commission. Can you talk about that work and what you think needs to be done to strengthen CSOs?
Dr. Tedros said it was a watershed moment when he met us for the first time. And in his words, it's not that WHO does not engage with civil society. It's the different programs and the leadership who choose to engage with civil society. So this is the first ever steering commission, which is institution-wide, where they have a very strong, they should arrive at a very strong sense of what it means for WHO to value and engage with civil society in a continuous and all over institution manner. And so we have some working groups. We're figuring out, we don't have a civil society engagement strategy yet. That is the first big output that we would have. And so we're inviting, civil society to be part of those working groups, be part of the commission. We already have 200 civil society groups from all over the world, but, if you go on the WHO website, there's a link to participate and engage in the working group. But we think it's ambitious, but we look forward to it because institutions like WHO, they're not the only ones, have been traditionally engaging with the member states. And then the member states choose to engage with civil society in whatever form they want, whenever they want. But this is something that gets institutionalized. And so we're very much looking forward to crafting that roadmap and inviting others to join in.
Thank you. Petra, turning to you. So I was in a taxi yesterday en route to a vaccination event, and I said I was here for WHA, and the taxi driver spoke to me about how dangerous vaccines are and how COVID-19 was biological warfare. So there is very much a disconnect from the conversations happening here and a large portion of the rest of the world. I'm wondering so in your work, what role do people in the innovation and development landscape play in kind of lessening vaccine hesitancy and kind of ensuring that once innovations are created, they do reach the last mile?
I don't think we do enough. We've seen enormous increases in vaccine hesitation and hesitancy over the last 3 years. And part of the zero-dose children pandemic, which is growing, is because young parents don't vaccinate their children anymore. How do we fix that? I think, again, it's a community discussion. We should not assume we know what the fears in the communities are. We should not assume that they're not educated and that we need to educate them around vaccines. I think there's components of giving the freedom of knowledge and the freedom of understanding in a two-way conversation. However, I also want to mention that we have seen the networks, the social media networks, the drives, the misinformation. I think it was mentioned earlier in the pandemic accord. It became so visible. Those engines are massive. They are powerful, they are well constructed, and they drive a message which is an anti-vaccine message. We as a scientific community, even public-private partnerships, have not mobilized sufficiently because we don't engage at various levels of the communities on a level of we are actually partners on a route to health. And we need to fix that. If we don't, there's many concerns around global health. There's concerns around producing vaccines, but never vaccinate the people and never have the benefits of those products. So this is a huge problem that we as a collective need to address in a partnership model.
Okay, we have, sure, please.
In conclusion, today is World Menstrual Day. Yeah, please remember that. Yeah, that we want a world that is period friendly. And I just want to give in 30 seconds an example. So I want to kind of rescue the word that I started with a little more so that I leave you feeling better and Devex feeling better. That the Oxford Dictionary also talks about empowerment as making stronger, more confident, especially in claiming people's rights. Okay, so there's also that side as well. And that side, and the reason I talked about the World Menstrual Day is in countries have committed, for example, to say we are going to provide free menstrual hygiene to all girls. Then how can institutions do that? Institutions like in Kenya, when the parliament passed that law, we need to go to the girls and say, by the way, this law exists. Please go and demand for those things. So that's also part of empowerment by Oxford. So I think we need to remember, celebrate the World Menstrual Day, but also remember we have the ability to give the knowledge and the means to the communities to understand what the rights are and demand for them because they're the ones with the power. So we are only giving their power agency. And therefore, as a community here, the final point is, we know that it is wrong actually for the AFVMA to be launched in Paris. Yes. We are a community. What are we doing about it? Thank you.
Thank you all. We've unfortunately run out of time, but I appreciate all of our panelists.
All right, thank you. We're actually going to start the next session with a video as well. So if we can tee that up. And then I'll ask my panelists to get ready to get on stage.
Across the global south, the current handling of vaccines involved the use of conventional methods such as ice boxes or frozen gel packs. Ice packs melt throughout the course of the day, compromising the vaccines and making it challenging to reach far and inaccessible areas of immunization. It can even damage the freeze-sensitive vaccines. WHO data suggests that about 50% of vaccines are subjected to suboptimal temperatures before they are administered, and last-mile wastage is particularly a problem in the low and middle-income nations. As a solution to this, we at BlackFrog Technologies have spent over 5 years of rigorous R&D to develop our flagship product, mVolio. We offer a backpack-mounted solution that precisely maintains a preset temperature for over 24 hours with no power backup. BlackFrog's patented technology is energy efficient for harnessing solar power in low resource settings and can be used as a standalone refrigerator to store vaccines, whole blood, oxytocin, and thermally sensitive serums at remote facilities. Additionally, IoT-based tracking enables health authorities to determine the effectiveness of vaccine and immunization coverages to inform value chain decisions. The product adheres to the highest medical device standards and is the first product to be pre-qualified by WHO as a battery-powered refrigerator. BlackFrog Technologies is a healthcare technology company based in Manipal, India, and we operate an ISO 13485 certified medical devices manufacturing facility. Our products are now live in over 15 states of India, with our technology demonstrating the value over conventional systems in deserts, coasts, and even mountains. With renewable energy partners such as Selco Foundation, we help deliver over 200,000 doses of vaccines in some of the most hard to reach areas. We are now scaling this technology to reach zero-dose children who are in critical need of vaccines, beginning with our deployment across Africa with the support of USAID. This will be the first step towards our broader vision of building a future epidemic preparedness and strengthening global health security.
Thank you. I would love to welcome to the stage Amit Kumar Rawal, who's Qualcomm Aware Platform Business Development at Qualcomm Technologies, and Mayur Shetty, who's the Chief Executive Officer at BlackFrog Technologies. Thank you both for joining us. Yeah, you can sit here. Great. Well, we just saw a video, Mayur, and I wanted to just kick off with you. Can you talk a little bit about the technology that we just saw in this video? What inspired you to create this? And maybe talk about some of the impact you've seen since you've done so.
Sure. The inspiration behind Embolio, automobile engineer. I spent about 4 years studying how petrol burns inside an internal combustion engine and how can I make it slightly more efficient, about 2%, 3% more efficient, so that with a liter of petrol you can go a slight bit further and a slight bit faster. Now, over the past 10 years, with the advent of electric vehicles, and electric vehicles have essentially taken over the world, also rendered my training mood, and my degree is about as useful as a floppy disk today.
So career preservation.
but it's given me some valuable insights that I've been able to take into the vaccine logistics space. Immunization is without a doubt the most significant and most important public health intervention. And I don't want to get into that because there's been a lot of conversation on the value of immunization throughout the day. But vaccine logistics, that's something that I want to speak about today. Over the last 50 years of immunization campaigns, there's been a lot of investment in vaccine cold chain. Some cutting edge technologies in refrigerated airplanes, Iceland refrigerators, solar driven refrigerators, but it's the last mile. Even today, we use ice packs, ice and gel packs to carry vaccines in that last leg of the journey, which ice is very cheap. It makes sense if it's a point A to point B journey, right? If you're carrying something from a grocery shop and you want to take it back home, even if you have a pit stop in the fuel tank for the fuel tank, it's still fine. But immunization is a little more complex. You need something that is actively controlled, where there is accountability, there is monitoring, and there is regulation. With ice packs, you're just not able to regulate the temperature inside these carriers. That got us thinking. That got us thinking into developing an active carrier where it strictly maintains a temperature that is preset for vaccines, and health workers can take it to far and remote areas without worry that ice packs will melt through the course of the day. Am I going to administer a vaccine that has potentially lost the potency? Right? That's what we wanted to build at BlackFrog, so that every child in every hamlet of the last village gets immunized. It's about efficiency. What we learned from electric vehicles is that just because something has been doing the job for such a long time is not exactly the best way to do it. It's not the most optimal or even the cleanest way to do it. That got us thinking into developing a very radical solution to the last mile delivery of vaccines.
Well, I think you have a little show and tell right here too, so we can see the backpack right here in person. I'd love to hear, what were some of the challenges in getting this implemented at scale, whether it was financial or regulatory, just adoption. Can you talk us through some of those challenges and how you overcame them?
Sure. Yeah, so I think right off the bat, the first challenge was a physics hurdle, making kind of miniaturize it, make it portable, make it operate in the global south, right? That was probably the first challenge for us. I think it's very easy to administer vaccines if you live in Copenhagen or even Addis Ababa or even New Delhi for that matter, because people come to the vaccines, right? It's the real global south, the mountains of Northeast India, mountains of Manipur and Meghalaya. That's where you need to carry vaccines to remote and inaccessible areas. I think that was the first challenge, to make it durable, portable, rugged, so that, I mean, it's going to be carried in bullock carts, it's going to be carried on a camel, it's going to fall off the camel, but it needs to be resistant to torrential rains. That was definitely the first challenge, and I think we overcame that with we had a clearly laid out design specifications by WHO PQS. There was a very well thought out specifications laid out. So I think that was the first step added. The second stage is making it leveraging the wireless compatibility of a battery powered system. So if you're using a battery powered system, there's a whole lot of data that we could potentially utilize, and that's where Qualcomm technologies came into the picture. We use Qualcomm's LTE. We're able to harness every single data that we get when you go on an outreach session. Like, for example, where is the asset going, who is getting immunized, who is being left out, are the vaccines safe, is it within that temperature, where is it being opened, where is it being closed. All of this data we're able to now leverage, and that's going to help inform value chain decisions. So yeah.
Well, and I mean, I'd love to hear a little bit more about how Qualcomm partnered with BlackFrog on this, and really how you go about developing innovative technologies, particularly looking at the pharmaceutical cold chain, and what led you to want to partner with Mayor and BlackFrog Technologies on this one specifically.
First of all, thanks, Kate, for asking this question, and good morning and even good afternoon to the crowd out here. I mean, let me probably divide this question in couple of parts while sharing my response. First, we need to double click basically when we look into the pharma cold chain and the problems what all of us looking in this room or maybe outside the room. It's all about getting the medicines and the vaccines in a right shape and size. That means I'm talking about the integrity of the cold chain. Number two, it's all about unparalleled transparency in the whole value chain. That means if I'm a government official, if I'm a community, if I'm a healthcare worker, or even I want the medicine themselves, I want to have a full visibility. Third, how they are stored, how they are traveling across the value chain, and last but not the least, if any tampering, theft protection can be done proactively. These are the problems what we are talking about today. Having said that, like you asked, pharma cold chain, we as a Qualcomm leader in wireless technology, we cannot just talk about just from the tech point of view, right? It has to have some human touch, some business touch, some tech touch. That said, we have a proposition. It's called Qualcomm Aware Platform. The word itself is like making everyone in the value chain, making aware. Kind of a platform we are talking about being a chipset industry, chip to cloud value proposition, cutting through complexities across the value chain as you move forward. What does that mean? I mean, so many buzzwords, cutting the value chain, technology, and so on. See, first thing is that when I was talking about the key problems at the start, having your connectivity right, that means that the positioning, where the vaccines are actually one. And for that, you need to have real-time, uninterrupted data streams on a platform, something which you could look into, all the stakeholders here in the room and the outside, number one. Locating the vaccines itself, like I talked about, being stored. So that we do with the kind of a location value proposition. Third, condition monitoring. It's very important. The pharma cold chain, in what temperature range they are. Are they getting somehow missed the pressure parameters they are into, the humidity, light sensing, and at times, basically, like I talked about, a kind of a platform one can use. And having said that, we feel empowered and very responsible while doing this.
When you talk about the human aspect, and when you saw the video, you see community healthcare workers using this backpack and engaging directly with patients. Can you talk a little bit about the role of community healthcare workers and your experience on how this technology is enabling their work to be more efficient?
Right. Yeah. So the fundamental priority for us was to provide a cutting-edge tool for the healthcare workers. In India, we call them the ASHA workers, the auxiliary nurses and the midwives who carry the vaccines. And these women are super driven by this idea of improving my community and ensuring my community is protected from these vaccine preventable diseases, right? So when we started deployment in India, we realized that a lot of our products were being seen as a means to an end, just to carry vaccines, right? It's only after time that we started conducting cold chain seminars. We started creating this awareness campaign where we showed them data logger studies. So we validated the product in about 4 states right now, in the mountains, in the deserts, in the coast. And we collected data with these wireless sensors inside the ice-based carrier and the same wireless sensors inside Emvolio when you carry the vaccines. And we could see that ice boxes would freeze the vaccines for about 4 or 5 hours before it's being administered. So there's a very high chance that we're giving vaccines today that could have potentially lost the potency, and these are being given to infants. When we showed this data to the health workers, they could really resonate with that, where their work is not really translating into impact because of a blunt tool, right? I'm sure a lot of you can empathize with how annoying it is when you use a screwdriver that just slips, the plastic part slips inside the metal shaft, right? And that's essentially what's happening. And I think a fundamental part, a fundamental tenet of a new intervention is adoption in the ground. And for us, it's with the healthcare workers who carry the vaccines. So a lot of the design for Emvolio has come from the field, where we've been able to interact with the healthcare workers, kind of understand their challenges. Like, for example, this has got a backpack. So this works really well in Ethiopia and Kenya, because there's a lot of men who carry the backpack. Whereas in India, women wear a sari. So when you're wearing a sari, it's very uncomfortable to wear a backpack. So we had to kind of adapt into that scenario where we could get a sling to ensure that it's not more of a liability than it already is with the ice-based carriers, right? So I think that's also the first rule of management, right? Putting the customer first. In our case, putting the end user first was always the priority for us.
And you talk about the data that you're able to collect and your platform. What are some of the other possibilities and potential you see that you could potentially build in with a device like this and leveraging all the data points you're able to collect?
Data is the new oil, I would say, in today's world. We can't disagree that. And that too, most important is having the trustable and reliable data. What we bring here, the innovation, what we do, it has got a purposeful innovation. What does that mean? I mean that in a healthcare value chain, if you look into even the topics Mayur was highlighting, and I was hearing some other sessions, it's all about getting real-time, trustable data in a certain manner, what the stakeholders and the community is asking for. Having said that, you take it, start from, like I was highlighting, let's pick up a healthcare, a value chain, and integrating it with let's say, pharmaceutical. Yeah, it starts from when the vaccines or the medicines started from the warehouse, getting to the last mile, traveling across the global. There are many touch points. You need to click on that and want to get informed. So those are the couple of things what we do take care of. Like I said, trustable, reliable data driven by Qualcomm Aware.
And so we are here at WHA. I believe this is your first time to. Okay. And what are you wanting to get from the global health community? And as a tech entrepreneur, what are some of the challenges but opportunities you see in partnering with the broader global health community to be able to leverage the technologies like you're doing to enable their work?
Yeah, so I think a lot of the focus now is going towards building a climate resilient health center, right? And that's another priority for us. And through the WHA, we're now scaling our work. This is something that's validated across India. This is something that we want to bring to Africa now. And we want to partner with development agencies to kickstart this, specifically starting with Kenya and hopefully the other nations after that. We want to be part of building a system where a health center is not cut off from the rest of civilization because of natural calamities. I mean, we've seen this in India where cyclones and hurricanes just cut off all of the power lines in the power grid, and the health center has no access to power, which means refrigeration, oxygen concentrators, everything is suddenly cut off. So solar compatibility is the future, and that's also that was also a design premise for us when we built Emvolio.
to make it as energy efficient as possible so that you can connect it into a portable solar panel. And that's something that we have outside. We have a stall outside. I would love to have each of you come over and look at the device and the solar panel as well. But yeah, to just wind up on the answer, I would love to speak to each of you to help us scale this technology in Africa now. I'd love to talk to you more about how we're at the forefront of ensuring immunization services are not cut down just because of a natural calamity or any even human error, which leads to cold chain transmission getting cut off, right? So that's something, yeah.
Well, in a lot of our discussions this morning, we've talked about the power of partnership and how critical that is in order to be able to scale the amount of work that really needs to be done to solve the vast global health challenges we're trying to tackle this week. So, Amit, I'd love to hear from your perspective how you think about partnership in being able to scale the reach of the technologies you create and invest in.
Absolutely, very, very interesting question, and I'm feeling myself already empowered answering this. Why? Because as you saw, Black Frog Technologies is one of those partnership wherein we brought in our tech to empower the community and contributing to the human progress. Having said that, I mean, as you can see, Qualcomm Wireless Reach, one logo actually out there. What is this? This is a strategic transformative initiative, I would say, which we have started a decade back. I mean, precisely somewhere 2006, and working in more than 50 plus countries, part of 130 programs, and more interestingly, impacting 27 million plus people actually. That means taking to the each aspect of the human life and contributing towards the progress of it, communities, and so on. And like I said, I mean, in one of my previous response, we taken it to the next level with the Qualcomm Aware, basically, where beyond connectivity, we brought in other key components. So yeah, that's how I would summarize.
And we are going to open up to some audience Q&A in just a minute. But how many of these units are in circulation?
Yeah, so we have about 1,100 units live right now. We helped carry over 200,000 doses of effective vaccines to some of the most rural and remote communities in India just after COVID. Both COVID-19 and routine vaccines, considering routine vaccination kind of took a backslide because of COVID vaccines. We also help deliver other critical biologicals, like for example, oxytocin, which is necessary for childbirth, right? You have home deliveries where you need to carry oxytocin. You need to carry antivenom in a lot of places where there are snake bites, blood culture, serum, sputum, lot of biologicals that require strict temperature control round the clock. You need emergency pints of blood every time there is a trauma incident. This is kind of our focus also. I mean, to ensure that it's not just a vaccine carrier, it's a holistic refrigeration solution for all of primary healthcare requirements.
Great. Well, if there's any questions in the audience, raise your hand and we will have a mic runner come around. Yes, we have one right here. Mic is coming your way. You can stand up and introduce yourself.
Thank you very much. I really appreciate this technology advance. My name is Professor Kihara. I'm from Kenya. And I know you're working in the Samburu area. But my question is, how do you get through the regulatory framework? And then how do you sustain and scale as part of your innovative advancement?
Right. Yeah, I think that's a challenge for any startup company in the medical device space. The regulatory board, I wouldn't say burden, the regulatory affairs around medical devices. I think that's a challenge, especially in the global south, where there isn't continued sustained funding for startup companies. There's too many valleys of death. Fortunately, we've had a lot of partners who had our back. Qualcomm is definitely one of them. Apart from the exceptional chips that they make that we use, they've also been a long-time big brother for us through a lot of these valley of deaths. The regulatory affairs, I mean, considering it's a medical refrigeration, we didn't have to go through a lot of the clinical trials. We had a fairly straightforward pathway with WHO. WHO has very specific guidelines for vaccine refrigerators. But yeah, that's also been an arduous journey for us. Considering we were the first one to be pre-qualified, they were very, very strict with it. It took us about 24 to 36 months to kind of completely wrap up the process, which is not exactly nice for a private investor. They don't have that kind of patience, which is a little troubling, but I'm hoping that scenario is going to change over time.
Great. Do we have any other questions? Amit, did you want to respond to that one as well?
Yes, sure. I would dissect this question in three ways. See, you talked about regulatory, right? I mean, how we do take it responsibly. Let's take it global manufacturing practices. Yeah. What we do, like I talked about, it contributes to the purposeful innovation. When we manufacture, we take care of good manufacturing practices. Number two, I will dissect that into as a good clinical practices, good clean, that we also take care of, because so many intrusions have been happening, being at the clinical trial site or throughout the value chain. Third, in fact, I would take it like good distribution practice, which is also a very key important throughout the value chain. So we cut across all these three aspects, addressing these three aspects: GMP, GDP, and like I said, GCP.
Great. Well, if anyone has any questions, raise hands, but I've got plenty of others here. So I think you started developing this pre-COVID, that's right. And then I'm sure once COVID hit, it became even more critical. Can you talk about that experience, and did it help supercharge this to be able to get it to market quicker, be able to get adopted quicker?
Yeah, absolutely. We had our beta version rolled out slightly prior to COVID. We were transporting biologicals, critical biologicals. Again, nobody really spoke about vaccines prior to COVID-19. I mean, outside of Geneva, probably. It was very difficult.
And taxi drivers in Geneva.
This is very difficult space for us to talk about vaccines are getting spoiled, vaccines are getting spoiled. Just nobody listened to us prior to COVID. During COVID, just during the when the first outbreak happened, we started deploying for transport of the samples, the nasal and throat swabs that went for testing the COVID-19 specimens, right? So a lot of private hospitals purchased from us. This is interesting because even the nasal swabs, their viral load, right? They require the same strict cold chain, and if they're not maintained in the appropriate cold chain, it could come out as a false negative. And interestingly, I contracted COVID in the mid of 2020, and I was at home, and a laboratory guy came home to collect my sample. He came in, he took the swab, he put it in a tube, and he just put it in his denim pocket, and he just walked away. There's no cold chain, forget cold chain. There's not even a polythene bag to carry it. And I knew I was absolutely certain that this is a negative test result. So which is a huge problem, because there isn't that awareness among a lot of health practitioners that a lot of biological samples also need to be maintained in that strict temperature, right? I think the larger break probably came through when the COVID vaccines finally did get approved. I mean, that's when the world's focus went towards COVID vaccines. Right? When am I getting my vaccine? That's when we were able to ensure that the largest impact of the product could reach the masses, right? And we hold these pharma companies to very high standards of like how efficacious is your vaccines, what are the trials. But the true benefit of a vaccine is only realized when that child has finally received the protection against the disease. So I think we tend to overlook that last aspect of, has it been delivered in the appropriate conditions, not just is it tested well enough. I think that needs to be part of the larger discussion.
Yeah, critical part of that whole system. Well, thank you to Qualcomm and BlackRock Technologies. We are going to have a break, and you'll have an opportunity to even interact with their technology, ask them any questions. They have a booth just outside. So we are going to break for networking out there. We'll be back in the room at 12:05. But thank you both. And please come find them to learn more about the technology. Thank you.
Thank you.
everyone. Go ahead and take a seat. Hope you had a chance to catch up, maybe meet a few new people. And we're excited to continue with our program here, where we are going to focus on adapting healthcare to a world in flux. So whether we're talking about the climate crisis, humanitarian crisis, NTDs, there's a lot of uncertainty right now, and we're going to spend the rest of our afternoon talking about how the healthcare sector can adapt to these. I am going to quickly hand it over back to Sarah Jerving for our next session. Over to Sarah.
Thank you so much, Kate. And if I could please be joined on stage with my panelists, that would be great. So we are going to be discussing neglected tropical, maybe we'll do right here, just and pass. Neglected tropical diseases in this session. And I am joined by Dr. Monique Wasuna, who is DNDi Africa Ambassador for Drugs for Neglected Disease Initiative in the center. Thoko Elfik Puli, who is Executive Director, Uniting to Combat NTDs. And Adam Weiss, who is the Director of Guinea Worm Eradication Program at the Carter Center. Thank you all so much for joining us. So neglected tropical diseases are a hugely important issue in impacting huge swaths of the world's population, but they're often overlooked and underfunded. So we're going to talk a bit about some of those challenges and success stories. So if I could turn to Thoko, and if you could talk a bit about some of the country success stories that you're most inspired by.
Great. Can you hear me? Yes. Excellent. Thank you so much for having us and making room for this very important conversation that is very dear to my heart. So for me, I think I just wanted to talk about two inspiring examples of elimination that we have seen. Two very different countries. One, Togo, which it became the first country in the world to eliminate 4 NTDs, which was extraordinary. And what was extraordinary about this is how political leadership played a big role. Because first of all, a country has to want to eliminate a disease. And they have to embed that within everything the country does, whole of government dedication towards elimination. So that was really key to Togo's success. Secondly, was how they funded their NTD program. I'm always struck that Togo started their LF program through Global Fund. They didn't actually have funding in country, but they embedded their LF. This is a program for eliminating elephantiasis within the Global Fund, and that kickstarted the work. So this was really a good way in which the country looked at innovative ways. If you've got the will, you'll find a way to fund that work. And then a third way was really the community health workers, how Togo was able to mobilize and harness community health workers who are really the engine of NTD elimination. I think we all owe it to all those incredible community health workers, many of them women who drive this disease elimination program, many of them going door to door. So some of you in the room, and somebody has said this to me, of course, Togo can eliminate 4 NTDs. Look at Togo on the map. It's a tiny country. You can run from the bottom to the top, Get Kipchoge in Kenya, he can run it in an afternoon. It's a tiny country, can do that. But what about Mali? A huge country, very complex, complicated issues, eliminated trachoma, one of the leading causes of infectious blindness in the world. This was really thanks to partners like the Carter Center here, over 30 years of dedicated work. And I think for me, Mali is an example of commitment and dedication, not giving up, keeping going, continuing against all the odds. So Mali is a great example. 2 very different countries, one small, one big, different challenging circumstances, but they're common denominators: political leadership, community health workers, dedicated, committed partners who are there for the long haul, who just are not there. Some people, they take on a program and then when things are tough, they give up. But the partners that are in the fight against NTDs are partners who do not give up. So those, I think I would say, as my opening gambit, these are the successes that most excite me.
Thank you so much. Adam, switching over to guinea worm. So you guys at the Carter Center work very in close partnership with ministries of health and governments. And can you talk about those partnerships, how you bring them together, and what sort of strengths do you see in them?
Thank you so much. I think we all know that partnerships really come down to building trust and building relationships. At the Carter Center, we're very fortunate to have a very strong leader in President Carter who helped forge many of those relationships and partnerships from a very high level. But what he was able to do was to bring together a cadre of people from the country level, but also internationally, who really focused on building those relationships. Founded in trust and mutual respect, respecting sovereignty of each member state, of local communities' sovereignty over their own challenges and problems, as opposed to helicoptering people in to then solve someone else's problems. So founded in all of that, building relationships requires us all to be active listeners and really making sure that we understand the needs of the communities. And so we've had the fortunate opportunity of working with many governments around the world, primarily for guinea worm in sub-Saharan Africa, Middle East, and Asia, and found many people who also had the drive and commitment and passion, which makes it easy to build partnership. Someone like McCoy Samuel Yibi from South Sudan, who would walk through swamps for days, climb mountains, be in very insecure environments, but always committed to serving his people. And it's very easy for us at the Carter Center to build partnerships and relationships around people who have that passion and commitment and drive. And so that's really what we focus on is finding people who are committed, finding people who have the passion, and making sure that we share tools and knowledge and understanding with each other. And as partners and even donors that help facilitate a lot of good work around the world, it's really about what the communities bring to bear, what the individuals bring to bear.
There we go. Dr. Monique, turning to treatments. So one of the issues with NTDs is there is not always adequate treatments because they're often overlooked and underfunded. And can you talk about the research and development landscape for NTDs, what you see as the gaps, and what are some of the solutions around that?
Thank you, Sarah. Thank you, all of you, for coming, and thank you for the invitation. NTDs is closest to my heart. Yeah, so about 20 years ago, there are very few medicines used for the treatment of neglected diseases. And in 2003, my organization, Drugs for Neglected Diseases Initiative, was created to fill the gap, the research and development gap that existed, because the doctors in their fields were very frustrated and the patients also were desperate because the treatments that were there were toxic, they're not effective, they are not easy to use, unavailable in some instances, and so my organization then was created to fill that gap. So then in 2003, going forward, the aim, therefore, was to be able to find treatments that would be effective and easy to use and adapted to the condition. So DNDi then, there were so many frustrations around that time because the infrastructure for research was not there. There was supposed to be a lot of capacity building had to take place because some of the countries we were working in had not ever done clinical trials before. So we had to build that capacity to be able to do clinical trials. One has to do clinical trials because it's a highly specialized way of saying that this drug works and this one doesn't work. So that needs to be done. And we needed to do it in the areas where the diseases were, in the endemic areas. So that capacity was not there. So that had to be built. Ethics and regulatory capacity also was fragmented. That also need to be strengthened, lack of funding, there was no money. So I'm creating all these gaps that were there that would impact on the research. However, then, DNDi decided people are dying, and we have developed two strategies. One is a short-term strategy where we then take a registered treatment and see if we can reduce the duration of that treatment or combine it with other treatments so that we can quickly give medicines for patients with neglected tropical diseases, especially in my favorite disease, which is leishmaniasis. So that was one, or repurpose the treatments that are used for other diseases, now to be repurposed to use for the NTDs, because that was the quickest. People were dying, so we needed to do something quickly. However, over the years, we also then developed long-term strategy, where we're developing treatments from scratch. And of course, that needs partnerships. As Adam is saying, you can't do it alone. A lot of partners, academia, universities, research institutions, everyone, civil society, researchers, everyone has to be involved. You need everyone to be committed and specialists in these areas. And so that's a long term. So now we are developing these treatments for leishmaniasis and for other NTDs. We have so far developed 13 treatments in the last 20 years that we have been in existence, 9 of which were developed in Africa, and I'm proud to say that, because they were empowering the communities, the endemic areas to be involved. And I forgot to say that we also work very closely with the governments, because you can't advance policy change without involving government and the World Health Organization.
Thank you.
So partnerships is key.
And just to dig a little bit more on the sustainable financing aspects, Hoko, can you talk about some of the challenges around that and what you see as some of the solutions to make financing more sustainable?
Great question. I was at the World Bank and IMF spring meetings recently, and I think the picture of our global economy was just really one of great concern. So if you look at the African continent particularly, a third of African countries are in debt distress. 12% of revenues are spent on interest payments. We have in Europe right now, those that are watching the European elections, great concern about the rise of the far right. And when that happens, it means that funding for development is just not going to be a priority. On top of that, we've got the great Devex. I think you did an article on the great replenishment traffic jam. We have Gavi, we have Global Fund coming up, we have WHO with their investment round of 7.1 billion. We have IDA 21 in December with, I think, 30 billion per year, which is needed for IDA 21. So you've got, on one hand, this really challenging fiscal space, and on the other, the growing demands for global health and development at the same time, which altogether really paint a concerning picture that we may not be able to meet everything that we need. And when you look at NTD specifically, this is something for me that remains shocking, because you've got these diseases that affect 1.65 billion people on the planet, diseases that are hardwired in the SDGs with some very serious targets to reduce by 90% the numbers of people requiring an intervention against an NTD. If you look when this data was done with the benchmark back in 2015 using 2010 data, right now, it means by 2030, we should reduce that number of 1.65 billion people requiring an NTD intervention down to 200 million. We are nowhere near where we need to be, and money is needed for that with all of these needs. So for us, really, we think that the biggest potential source of financing has to come in the form of grant financing to countries, and IDA 21 is the most important source of financing for countries that will finance neglected tropical diseases. So we're really encouraging a fully replenished IDA 21, and that within IDA 21, there is a focus on elimination diseases. We know that we are only less than half the journey towards 2030, and only 15% of the SDGs are on track to be achieved. So basically, we're potentially looking at a space where the world will be unable to meet its promises made to people. Those promises were made to some of the people affected by neglected tropical diseases, because this is about the leave no one behind agenda. Let's focus on those people that we forgot during the MDGs. And people affected by NTDs were one of them. So for us, we think we appreciate countries are in a huge problem, but IDA 21 for us is really the solution. We think fully funded IDA 21, and an IDA 21 that actually makes room, creates a flagship initiative for disease elimination for countries, so that countries can access that grant financing, not loans, not loans. Countries can't have more loans. They are already in huge debt distress. Grant financing that will enable them to deliver for some of the poorest people, and those are people affected by NTD. So this is our single call to action. Thank you.
Thank you. And in Thoko's opening remarks, she had commented on how community health workers are kind of at the heart of the delivery of treatments and whatnot for NTDs. Adam, I'd like you to talk a little bit more about kind of the importance of how do countries go about ensuring that their workforce is kind of trained in these diseases and have the tools that they need?
Yeah, great question. Fundamentally, it comes down to education, awareness, and providing the tools that your community health workers need. And oftentimes there's a discussion around guinea worm, which started as a very vertical program. But we have to remember that it started as a vertical program because there were no other structures available. And over time, as development has helped to fill some of those gaps, then you can look at a more integrated program and a multi-disease platform or lens through which you train and equip your workforce. But in the case of guinea worm specifically, going from 3.5 million cases per year estimated to just 14 people with guinea worm, of course, the challenges for us now is making sure that that workforce is sustainable in a way that they can continue to look for guinea worm, they can continue to look for polio in places that have eliminated various strains of polio, and making sure, again, that across the health system, the investments from all stakeholders really make sure that that fundamental training is there. Some of that can become institutionalized through the education sector, but oftentimes it's about bridging some of the gaps that the Ministry of Health or other sectors like Ministry of Livestock and Fishery and Environment also have to chip in with some of the technical inputs into training and equipping that workforce. But ultimately, what we deal with on the front lines with neglected tropical diseases is making sure at the community level, the workforce really is every individual in their community. You might have a representative who is a health extension worker or some type of health worker that delivers mass drug administration, but making sure that they're aware of the different signals for various diseases. We often talk about pandemic preparedness. What does that mean? What does that look like for people that don't use cell phones, that don't have access to electricity or basic infrastructure? And so making sure that they have the wherewithal, the knowledge of what these diseases look like, what some of those signals might be, and then what's the structure and system for reporting that information. If there's capacity then to respond, that's where a kind of multidimensional surveillance system can be very helpful. But you have to still be able to deliver some type of treatment or care at the end of that road, as opposed to just detecting a disease. Well, then what do you do about that? So I really view that, this is the long game, and making sure that our education systems are built and designed to meet the needs of the communities, which again, very diverse, very different contexts from a place like Syria or Sudan compared to what we might be dealing with in Switzerland. But you still need surveillance, you still need awareness and education.
Thank you. And kind of bouncing off that, Dr. Monique, just once you do have, you've developed treatments, there is that very important step of making sure that it reaches remote places, the last mile. there's the health workers, but there's also the logistic aspects of it. What would you say are the most important components in ensuring that access is there at the last mile?
Yeah, so I think I like to look at it in terms of even research and development. What we do is that we have to embed access right from the beginning when the project is being developed, because we need to know the type of medicine that we are going to develop. Who is it for in terms of the age? Who is it? Is it in terms of the women should also be able, pregnant women should also be able to have these treatments, women of childbearing age, because all these have been excluded from the trials before. So we have to think about them so that at the end, when the treatment is available, all these other questions have been taken into account in terms of how effective, how efficacious do we want it to be? How do we want to give it? Do we want to give it orally? Do we want to give it by injection? What is the best? What is the safety profile of this treatment to be developed? So all these things have to be thought well before. And also in terms of this drug, when it's available, what interactions, how will it interact with other existing drugs? So all these questions have to be answered in the process of the drug development. And so then when you get your drug, then it's a different ball game, because then now is when you need like WHO, yeah, because the results of the clinical trials have just come out. So WHO has to evaluate the studies to see that, truly this drug works. And then, of course, advise the governments, the nations that this drug works and you can, it's a first line or second line and so on. So that advice is a technical advice to countries, because some of the countries who are having these problems don't have that technical expertise. So WHO does that. Together then with the ministries of health have to take their rightful place, because they also have to decide that they want this treatment, because it can't be pushed through their noses or through their mouth. They have to say, we want this treatment. We have also looked at the data and we believe we want it. And then therefore, then they have to change the guidelines. Yeah, the national guidelines have to be changed to accommodate the new treatment. So policy change must take place, because you can't just go from the lab to the patient. It has to go through the policy. So once that is done, the governments then put this drug on their essential medicine list, which means that the country can buy that medicine, they can bring it into the country. Of course, they use their regulatory mechanisms of approval to do that as well. And then after that, it doesn't stop there. So we support also the training, because if we, together our partners, produce this treatment, we have to support the training of the doctors in the field, how to use these treatments, and then how
to make sure.
Yeah, and all the side effects and everything we teach them. But then ultimately, there are issues of procurement of these medicines and these systems in country. And I believe that the governments now have to take responsibility for their citizens. Because up till now, we're relying on donations, we're relying on other people. So I think it is high time that we also, who have their problems in our countries, also put in some money to be able to procure treatments and to the last mile, use these treatments for eradicating for eliminating NTDs.
Okay.
I think the R&D, just add one thing, that innovation is key for elimination of NTDs. And so the last mile will need everyone, including treatments and diagnostics. Yeah.
Okay, great. Well, just last thought from all of the panelists, just kind of one line or so. What would you like to see out of the international community on NTDs? Soko?
A fully funded IDA 21 that has neglected tropical diseases as a flagship initiative focusing on disease elimination. Let's get the job done and celebrate success in 2030.
Thank you. Dr. Monique?
Yeah, sustainable funding for research and development would be key, and partnerships. We need everyone in this.
I think we're at a critical moment where political will is the best I've ever seen. In 21 years of working on disease eradication and elimination, the politicians are standing up for the people, generally speaking. And I think making things local, to build off of Dr. Wasuna's comments, developing diagnostics, developing tools locally, whether that's on the African continent or other continents, where they can be used and delivered easily with less supply chain management related issues, being as local as possible.
Wonderful. Thank you all so much for joining us today.
Thank you. Thank you.
Hello. Hi, everyone. I feel like, okay, first, well, I'd like to welcome to the stage, of course, Dr. Marina Romanello, Executive Director of the Lancet Countdown on Health and Climate Change. I feel like this is a reunion because we were at COP28 last year, not on a stage, but in a cubicle talking about climate and health and fossil fuels. And so I'm really happy to have you here with us today. Okay, so at COP, we were discussing, and one of the things a powerful message really about you delivered was about the critical importance of phasing out fossil fuels. And I'm quoting you here, and you said, fossil fuel phase out is the most effective and the most important public health intervention of our times. Could you elaborate on what fossil fuel phase out looks like in practice at the moment? And based on the findings of the Lancet Countdown reports, I know you've released regional reports recently. How is this phase out currently impacting global health outcomes?
So, on the basis that climate change is affecting the most fundamental pillars of health, climate change is affecting neglected tropical disease transmission, it's affecting the quality of the air that we breathe, the water, the food that we depend on. So it's really undermining the very basic building blocks of health. And the oftentimes catastrophic impacts of climate change that we've seen up until today are happening at about 1.2 degrees of global mean temperature rise. Current policies and actions, things that we're actually doing to tackle climate change, put the world on track to 3 degrees of heating. We don't know quite well what 3 degrees look like because our models break at 3 degrees. Our epidemiological models, our human models don't work under that level of climate uncertainty. But what we do know from what our models do tell us is that that future could be really disastrous. Could be, as I said yesterday and I repeat today, could be a death sentence for millions, if not billions. So tackling climate change and avoiding that sharp increase in temperatures is the most important public health intervention that we could do. It's a life-saving intervention. And the main source of that heating is the greenhouse gas emissions that are emitted by the burning of fossil fuels. So we know we need to tackle fossil fuels. We know that fossil fuels are incompatible with a livable future. And that's what the IPCC also told us. But on the flip side of that, there's also the other harms that the fossil fuel industry does to health. And we have estimates that say that annually we lose about 1.2 And there's a new study that says up to 5 million lives each year from outdoor air pollution that comes from the burning of fossil fuels alone. Add on to that the impacts of indoor air pollution from the burning of fossil fuels, and from the fact that a high dependence on fossil fuel has limited our capacity to transition to clean fuels. And what that looks like is that in many countries around the world, we're still highly dependent on burning not only fossil fuels, but also biomass. That many populations around the world are still heavily dependent on unreliable and unsustainable sources of energy. And that means that people not only suffer from the impacts of air pollution, but also all of the disadvantages to development and to health that come side by side with energy poverty. So transitioning away to fossil fuels and towards clean sources of energy and energy efficiency could mean that people have access to off-the-grid energy, clean sources of energy, much more reliable energy in places that are most needed. And we're not seeing that transition yet. So you ask me, what does this look like today? It looks like very high Human Development Index countries produce about 11% of their energy from clean, renewable energy. But low Human Development Index countries are only at 2%. So those countries that are most burdened by energy poverty are not enjoying the benefits of the new technologies for energy generation.
You mentioned about the importance, of course, of transitioning out of fossil fuels, but there's this concept of just transition, right? Can you explain what a just transition entails and why it's so crucial from a public health perspective?
Absolutely. So this is what it looks like. It looks like we cannot leave behind half of the world as we transition towards a new world order. We know that we have international commitments. We know we need to tackle climate change. We need to do our very best to keep to that 1.5 target. That's the best chance of survival. And what that means is that we need to reorganize our whole economy. We need to reorganize the way in which we access the essential life and health supporting services. But in doing so, what we're also seeing is that it's the high-income countries that are leading the way. So the technologies are held in high-income countries. The advancement of that new economy is mostly in high-income countries, which means that we're leaving the so badly called global south behind. And we're again generating this divide in the way that we transition to a healthy future. What that looks like in an example is what I was just saying about access to energy, is the fact that the most vulnerable communities, the poorest communities, still depend on dirty fuels, are exposed to toxic air in their home where their families live. But it also means that in many countries, we're seeing still a high dependence on fossil fuels. And we've seen this particularly in much of the conversation about air quality, where the public-private partnerships are being made with the oil and gas sector, with the fossil fuel sector. And that means that the fossil fuel sector is looking at these emerging markets, is saying, well, how do I keep on selling gas to countries that are lagging behind in the transition? So we're locking in places like Africa, like South America, like South Asia, on a dependence on gas that is also harmful for health, that is not easily available, that is expensive. And that means that those countries will not be able to transition easily and will depend on global international companies on fossil fuels. And why that is important for health, we've seen it over the past 2 years with the energy crisis. We've seen what the energy crisis did to people, what it means not to be able to afford energy because you're dependent on international fossil fuel markets that are highly volatile. We've seen what it means not to be able to afford the basic services for a healthy life. The flip side of that is also that we keep on investing in jobs that will not exist in the future. So how are we going to support the next generation in sustainable livelihoods, in accessing essential services, if we keep on undermining the transition to what the future will look like, particularly in the most vulnerable parts of the world? And while all of this sounds a lot about energy and economy, we have to understand that the economic and the social determinants of health are the most fundamental determinants of health, particularly in those countries in which those determinants are so frail.
What do you think can be done? Because, we need to really, work toward phasing out fossil fuels, but we can't leave, the global south countries, especially some of the most vulnerable countries behind.
So we need many things to happen in parallel. But I think the most important one is, as we have been hearing just now, is those partnerships and those cooperations between high-income countries, low-middle-income countries, and good international agreements for knowledge transfer, for technology transfer, and for grants, for funding that is granted, not loaned, to support low-middle-income countries for the just transition. There's very many financial mechanisms that were implemented in the context of the UNFCCC. There's very many financial mechanisms mechanisms in the context of the WHO and other health frameworks, what we need to ensure is that those go hand in hand, that when we transition to a net zero carbon future, that we're transitioning also to a healthy future, that we're leveraging on those opportunities to ensure that, for example, we don't leave people without access to energy as we transition away from fossil fuels, that we fundamentally protect people's well-being, the development, and the fundamental determinants of their good health and lives.
Well, I do want to invite over on stage. We also have two more excellent panelists, of course. Shweta Narayan, International Climate and Health Campaigner with Healthcare Without Harm, and Omnia El Omrani, Climate and Health Policy Fellow at the Imperial College London and COP28 Health Envoy. I think they're having a reunion right now on stage because they're all at COP as well. I'm going to start with Shweta. You know, at COP, there was a celebration among the health community because it's the first ever health day during COP, right? And so, increasingly, health professionals see the importance of transitioning out of fossil fuels. However, what more do you think health professionals can and organizations can do to drive this transition? And why is it so vital that the health sector be at the forefront of this effort?
Thank you, Jenny. I'm a campaigner, and my basic job is to repeat. So I'm going to repeat a lot of what Dr. Marina has already said. But just thinking about health professionals and their fundamental duty is to protect people's lives. That's their moral, ethical, social duty. And when you're thinking about protecting people from the climate crisis, you cannot not talk about the root cause of the climate crisis, and that's fossil fuels. So it's not a luxury for the health community to talk about or a choice. It's just that their moral duty to talk about if they are really concerned about protecting their patients' lives. And I think the health community, which doctors, nurses, frontline responders, community health workers bear witness firsthand to the impact of on the health of their patients in their clinics, in their communities. So they are the most authoritative voice who are backed with evidence and should be talking in any platform about addressing the root cause, and that's fossil fuels. So that's what the health community did in the lead up to COP28, where they demanded from the world leaders a rapid, just, and equitable transition away from fossil fuels. And we heard what the whole concept of the just transition is, and why it's called just transition is because just is justice. So it's not just energy transition or jobs versus jobs. It's about health equity and climate justice at the core of this transition. And who better than your doctor and the nurses and the health workers to talk about what we are witnessing and what we need? So I think that's the reason why health community really needs to talk about the transition.
And it's not just about talking, right? Because according to the Healthcare Without Harm, if the global healthcare sector were a country, it would be the fifth leading contributor of greenhouse gases, with 70% of that coming from the health supply chain. So clearly, the health sector needs to decarbonize. And of course, this has been a focus of your work. But what opportunities and challenges are you seeing toward that, decarbonizing the sector? And can you provide maybe one or two examples to illustrate?
Thank you for asking that question. And that is the interesting paradox that we live with, that the health sector, whose duty is to protect people's health, is also contributing to the cause of people's illness by contributing to the climate crisis. And this is an important recognition. And also, as I said, the moral and social authority of the health community is to talk about phasing out of fossil fuels. You have to lead with example. You cannot practice something else in your own sector and then preach something totally different. And I think the health community is increasingly understanding the seriousness of its own sectoral footprint and also the authority that it has about talking about a transition. And in the last couple of years, we have seen an amazing momentum in the health sector in recognizing that there is a necessity to transition to a low carbon, climate resilient healthcare. And the reason why I'm talking about low carbon and climate resilient, because there's a slight nuance. The high emitter and high income country need to rapidly decarbonize and move towards low carbon health infrastructure. While at the same time, the low and middle income countries and low emitter countries need to invest in resilient low carbon health development, so that again, the health equity and justice is at the core of health development across the globe. I also want to make a comment that it's important that health sector transitions, and we are seeing those movements, be it health sector signing up to Race to Zero, or many health institutions making those commitments and setting up high ambitions of net zero by 2030, 2040. But let's also remember that the health sector cannot adapt its way out of this crisis. And that's where the authority to influence other sector also comes. You can build the best low carbon, climate resilient health facilities around the world, but if other sectors continue to pollute and continue to depend on fossil fuels, the health burden will remain more or less the same, and the health sector will always be overwhelmed. So yes, you have to lead by example, but you also that gives you the authority to also transform other sectors.
Now, there's this call really to go low carbon, build resilient health systems. I want to go to Omnia because, how can medical schools better prepare future doctors to navigate this evolving landscape and its implications for patient care, and how much of that is happening today?
Yeah. First of all, thank you so much for having me back with my friends here on stage. And I think this is a very important question, because when we talk about healthcare systems, we tend to talk about infrastructure, supply chain, but then a very critical building block in a healthcare system is the health workforce. And we are all, before we are doctors, we are students. And not just the medical education, but health curricula in general across all healthcare professions, whether nurses, doctors, public health professionals. It is so critical for climate change to be part of that. And I say this because as a medical student myself, not many years ago, I never learned about climate change in my own education, but I was very fortunate to be part of an international medical student organization across over 140 countries. And back then in 2020, during COVID, when we were all under stress and we realized that not only as our healthcare facilities and our education did not prepare us for a pandemic, but it did not prepare us for another health crisis, which is the climate crisis. So I decided to, when many of us had time off, to do a global survey across 112 countries. We had 2,817 medical institutions participate in this survey, and we asked a simple question: is climate change mentioned in the curriculum or not? And how is it mentioned? Is it a one-off lecture? Is it a course? Is it a mandatory course? Is it assessed? And we realized in our survey that was filled in by medical students that less than 15% of medical curricula worldwide had a mention of climate change. And this meant that over 85% of the future health workforce did not learn about climate change in their education. They were not prepared. And even if they were prepared, it was inconsistent. We did the same for air pollution. It was even less. It was less than 11%. But this helped us to mobilize as medical students, but we also had the support of medical faculties around the world. And we did a consensus statement that was adopted by many medical faculties, calling on the integration of climate change and planetary health at the core curriculum, looking into undergrad, but also postgrad. I'm very proud to say that over the last 4 years, I've seen how countries stepped up. The Netherlands has now integrated climate change across all the curriculum, across all the cities. In Egypt, in my own university, because of COP27 in Egypt, my dean decided to integrate climate change across all the faculties and not just the medical faculty, and to have climate change as part of that. And it is so important, not only because the health workforce is the one who is going to be the ones that will transition the healthcare facility towards being climate resilient and environment friendly. They are going to be the campaigners in the society and the trusted messengers, joining the global youth movement towards influencing countries not to backtrack on their promises, not to further invest in fossil fuel subsidies every single year, but also be the ones mobilizing that commitment and that accountability, because it is affecting us and our present and our future, and the children and the adolescents that we represent and that we speak on behalf.
It's good to hear, that there's progress. You're seeing that, you mentioned in Netherlands, in Egypt, hopefully, in more countries, in more institutions. Right now we're at WHA, and of course there's a climate and health resolution. Can you maybe talk about why is this resolution so important? Yeah. Marina, do you want to start?
So this resolution comes at quite a crucial point. It comes after COP28 last year, where we had the first Climate and Health Day. So with that, we introduced formally health within the climate negotiations, something that was long overdue. And now with this resolution and with the General Program of Work 14 as well, that acknowledges climate change as the first priority, we see climate change being incorporated formally into our global agenda for global health. One thing that has been really inspiring is over the 2.5 days that I've been here, we've been sitting with ministers of health. We've been hearing from leaders from different countries, low-income countries, high-income countries. And they've all been talking about how crucial action on climate change and health is for the health sector. That is something that did not happen before. And what is crucial is that this new resolution, alongside the General Program of Work, has now formally given that mandate to ministers of health, has told ministers of health worldwide, this is of your concern and it's your duty to take action. Because as Shweta said, this is the most fundamental determinant of health. This is a health issue, and therefore you need to be advocating for reducing that hazard, for doing what we call primary prevention, that is mitigating greenhouse gas emissions and reducing the hazards that we're facing. And now this is in everyone's agenda within their health ministries. So we're hoping that that will give us a lot more momentum for action from the health sector. One thing that is lacking, though, is first a mention of fossil fuel phase out, which, as Shweta says, is fundamental for health. So it's something that as health professionals we need to be advocating for. We know that it's very political. We know that there's a lot of pushback from big organizations and big lobbying, but we know that it's fundamental. But the other thing that we need is to ensure that this is not siloed in the health sector. The health sector alone does not have enough agency to act, but it has a lot of agency to influence other sectors. So what we need to see now is that it's not just about the ministers of health working with climate change, but actually that we're engaging in cross-disciplinary, cross-ministerial negotiations and agreements to drive this topic forward throughout the system that determines health and well-being.
You mentioned, of course, not just resolution, but that climate change is actually one of the objectives of WHO's new draft at this stage program of work. And it talks about having more climate resilient health systems and reducing the health system's carbon footprint. Maybe Omya and Shweta, you can jump in and talk about how significant is this?
Yeah, I can go. I think it has been, as Marina said, so inspiring to see the mobilization of the health community in the climate space. But then the challenge was, how can we reciprocate that into bringing in climate into the health space? And the WHO resolution is a demonstration of that the health community now recognizes how climate change is affecting all aspects of determinants of health, all the progress that we have made when it comes to infectious diseases eradication, and also the importance of mental health in this conversation, which climate change is impacting. And we cannot talk about health without recognizing the health of the environment, which we depend on. And at the same time, the resolution means that it gives ministers of health the mandate, the confidence, and the comfortableness of working on this issue, because then many organizations, whether civil society, academic institutions, youth-led organizations, are going to work together to support ministries of health to lead the climate and health programming for their countries and the action that is needed, because it has been a big gap. It has been so inspiring to see at COP that over 50 ministers of health came to the climate conference for the first time in 28 years. And they came with commitments and plans that they want to integrate. So it's important to see that continue beyond December, and to see that now as we are in May, and to see that continuation. And another important thing, many of you have seen how many young people are frustrated by the lack of urgent climate action and justice that is needed, including action on fossil fuel. But what they're doing right now is that they are going to their countries, they are using litigation to hold their countries accountable for lack of climate action. A resolution like this is another accountability tool that young people and other civil society can use when their countries are not acting on climate change, because now it is affecting their health, their future, their basic access to healthcare services that is so necessary. And I think it also gives us the motivation and the push to work together with countries to finally implement the climate and health solutions that communities, the most marginalized communities, need.
But from the point of view of healthcare without harm, how important is this?
I mean, again, I have to repeat this. This is huge. This is a big moment. This is, I think, the first step in breaking the siloed approach. So in climate negotiations, you'll not see the health ministries, but this really empowers. It's the first step in empowering the health ministries to participate and have a voice, and have a voice beyond the health systems, because climate crisis is a health crisis. So I think this really empowers health systems. This really empowers the World Health Organization. This is a huge opportunity. The only personal disappointment is the lack of mentioning of fossil fuels, because if we don't acknowledge that there is a problem, we will never find a solution. I think the first step in finding a solution is acknowledgement of a problem, and we are kind of like shying away because of all the politics involved in the fossil fuel conversation. I mean, I just want to leave everybody with a staggering piece of data. And the previous panel was talking about the need for funds. And, my heart was sinking as I was like listening to all the geopolitical development and the possible financial crisis in terms of like investing in health. Between 1970 and 2020, in the 50-year period, fossil fuel industries made a staggering pure profit of $3 billion every day between 1970 and 2020 for 50 years. That's the amount of money they're making at the cost of our health and our lives. If that money was invested in health development, the situation would be radically different. I think this is the first step. For us, this is the starting point. This is not the final destination. This gives us the opportunity to elevate the climate and health conversation in multiple.
Staggering number, of course. But we don't have much time, but just very quickly, maybe, Dr. Romanello, what should the health community look forward to at COP29?
Well, the COP29 will be a big COP on finance, so we will be having finance at the center of the conversation. Shweta mentioned the absolutely mind-boggling profit of the fossil fuel sector. There's also a huge investment being done by governments in terms of fossil fuel subsidies. There's a lot of money to go around. There's more than plenty. It's in the wrong places, and it's in the places that undermine people's health and people's well-being. So as we go to COP29, understanding how to divert those funds to supporting cleaner sources of energy, cleaner air, cleaner, healthier diets, healthier urban centers, and healthier future for everyone, that will be the priority. So we need the health professionals here to be talking about, as we just heard from the NTD conversation, about the finance that is needed, the grants that is needed, and in that sense, putting a lens of climate change. How is climate change exacerbating the funding needs, or how can that funding be redirected to increasing resilience as we deliver essential life-saving medical interventions to ensure that our healthcare delivery is resilient to a future of climate change, and to ensure that we have funding being allocated to those activities and those services that promote and improve people's health rather than harm it, as we're seeing with the billions, hundreds of billions that is every year going to fossil fuel subsidies.
Well, financing is always an exciting discussion, right? Thank you so much to our speakers.
Thank you.
Right, well, just a heads up that we actually will be hosting an event on climate finance and how we are going to fill that financing gap as we look ahead to COP29 during London Climate Action Week on June 25th in London. And we also will be looking at the intersection with health. So if you'll be in London that week, please join us. So I'm very excited to welcome back to the stage Sarah Jerving to lead our final session on combating AMR.
Thanks so much, Kate. If I could be joined on stage by our speakers, please. So we have Caroline Bolton, who's Global Program Head of Novartis. Dr. Otto Kars, who's Professor Emeritus at the Infectious Diseases, thank you, founder, and founder of React Action on Antibiotic Resistance at Uppsala University. Dr. Lucica Ditu, who is Executive Director of Stop TB Partnership, and Jeremy Knox, who is Head of Policy of Infectious Diseases at Wellcome. Thank you all for joining us. So antimicrobial resistance is considered a silent pandemic because it's a huge issue, but it's not getting enough attention globally. But it threatens to turn back the clock on a lot of advancements made in modern medicine, creating a situation where common infections could become untreatable and common procedures would become unsafe. I'm hoping, Dr. Kars, if you could please expand upon that, on the dangers of AMR and why pharmaceutical companies are not developing new antibiotics.
Thank you very much for the invitation here. That was really two questions. I actually tried to be quick. I mean, we are facing a situation where humans are outpaced by bacterial ingenuity. And bacteria are experts in behavioral change. We are not. So that's part of the problem. We know now that 1.2 million people die every year because the drugs, the antibiotics that are given. I will talk about bacterial diseases. We will talk about malaria and tuberculosis a bit later. So we know the burden is enormous. 1/5 of these are children, and most of the burden is in South Asia and Africa. Having said that, we also need to see that antibiotics is also challenging the health systems as such. All health systems in the world, even the weakest, are completely dependent on access to antibiotics to work. And what happens if it doesn't? The system will crumble. And we see the challenges, as you mentioned. Modern medicine is at stake now, for sure. We are talking about ethical considerations to treat patients with harboring multi-resistant bacteria in their gut flora with cancer because their risk of dying of sepsis is too high. Children, specifically the preborn children, are really at stake with sepsis. A major surgery and a transplant cannot be done safely without antibiotics. So we have not really understood and come to grips with the magnitude and dimensions of the problem yet. And that leads us to the second question, because why have we reacted too slow and also too narrow and too weak? Well, I think one answer to that question is not the answer, but one answer is that we have been relying for too long for the pharmaceutical industry to deliver new antibiotics when the old ones have been worn out, so to say, and stopped working. And that is obviously still the case for many. So I think we need to change that. And the question was, why are the big pharma leaving? Well, most people would think that that's an economic reason. Their profitability is lower than for good diseases, for chronic diseases and so forth. And that's absolutely true. That's one factor. But in fact, my belief, and I think I share that with many experts, is that the real challenges are the scientific bottlenecks, the barriers, to get a new antibiotic inside a bacterium with all the complexity of its shell and different layers and whatever properties you have to have. And that is not fixed yet. So I think, and one example is a recent example, a review article when they studied 48,000 potential molecules that could become an antibiotic. Out of them, 0 entered further development. So we have a major problem there to start with. So that was, and you know, the solutions will come later in the discussion, but obviously the public sector need to take a much stronger responsibility for the whole issue, including for development of the medicines we need.
Talk a bit about kind of research ecosystems and what a Wellcome Trust is doing to create those to combat AMR.
Yeah, of course. So Wellcome as an organisation, as a research funder, we've been very heavily engaged in AMR for really a decade or so now, and I think really trying to think about how we can mobilise our resources and mobilise our capacity and capability as a funder to make the greatest inroads. We're doing that in a few ways. So, for example, we spend a lot of effort trying to improve understanding of the AMR problem, trying to build evidence for action. So, for instance, we were a major funder of something called the GRAM study, which has given us kind of the understanding, the data on the burden of AMR that Otto described, and is starting to give us real country-level understanding of where the greatest burden lies, what are the key bacteria we need to be targeting. And addressing things like the antibiotic R&D ecosystem, this is one where we've really tried to take that ecosystem approach of thinking from end to end, all of these problems, all of these failures that are meaning we don't have the pipeline of products we need, how can we address that? So what does that mean in practice? For example, in early stage research, we were a founding funder of Carbex back in 2016, which is supporting a growing portfolio of drugs, diagnostics, and vaccines. We've been looking at the later stage problems, so a cliff edge as products mature through clinical trials and facing real shortfalls in funding. And we support something called the AMR Action Fund to support later stage clinical trials, but then also trying to think about other things as well. So for instance, how can we make clinical trials more efficient? So supporting clinical trial networks for antibiotics to make sure that trials can be done more quickly and more cheaply. And then finally, and kind of where I come in, is the policy side of things and thinking about the end market. Why is it that we have this market failure, these barriers to access and uptake, and what are the calls we can place on policymakers in terms of market shaping mechanisms, new ways to create incentives? So it's that type of end-to-end approach that we try and bring to a problem as complex as AMR.
Caroline, your company is working on combating parasitic resistance to malaria treatments. Can you talk a bit about the problem and then what your company is doing?
Yeah, thanks. So most people don't actually realize that resistance that occurs as a response to parasites is part of this AMR topic, but actually it's a huge issue in malaria. We have a long history of drug treatments failing because the parasite can adapt so quickly. And if you think about the situation 20 years ago, where the standard of care at the time, chloroquine, was used, actually there were probably millions of deaths because that drug failed. The standard of care that was introduced at that time was artemisinin in combination therapies, and now there's some evidence that those are starting to fail as well. So we're on a knife edge in terms of the way that we can manage malaria infections going forward. So actually, as the name implies, artemisinin in combination therapies, it's two drugs together. So you've got the fast-acting component, which is responsible for clearing the first malaria infection, and you've got a longer-acting partner drug. Now, all of the evidence suggests that there are resistance mutations out there to the short-acting drug, which means that the parasites are being cleared less quickly. And that puts all of the pressure on the partner drug. When the partner drug starts to fail, then we have treatment failure and we have patients potentially dying of malaria, which should not happen in this day and age. So what we need is new treatments, non-artemisinin treatments, which can reduce that risk of partner drug failure. And that's what we're working on as Novartis. We actually have a whole organization. We're still discovering new antimalarials, we're developing them, and we're trying to make sure that they get to the patients that need them. We actually have 3 programs in the clinic at the moment. We have 1 in phase 3, and actually we're developing these specifically to remove the threat of the resistance mutations taking hold in communities. And we're obviously also trying to make sure that
they're easy to use by communities because we know that poor adherence to therapy also results in resistance. So we're trying to fix the two things at the same time.
Turning to you, Dr. Lucicia, so drug resistance tuberculosis is one of the deadliest forms of antimicrobial resistance. Why is that?
Yeah, so thank you. I just want to mark a good star for Devex and this kind of panels because I'm tired of places in which people invited read a statement from a paper, and I'm really happy that we here speak free. So I actually actively push for a WHA without statements. So going back to the TB, to the question you had. So you see, tuberculosis is an airborne pandemic. Okay, I know that people are a bit worried to use these words because of political reason, but it is an airborne pandemic. And if there is something we are all at risk, is TB and its resistant forms, because we can take it in places very easy as long as we breathe. So the first reason, the first thing of why is so important is that it's everywhere and nobody can protect themselves. I am infected with TB and I'm a bit worried, what if it's drug resistance, okay? The second thing is that in addition to that, the resistant forms, the ones that we hear a lot is the multi-drug resistance. You know, TB is treated with a cocktail of antibiotics. The ones that capture the attention are rifampicin and a few others that are creating the so-called MDR. But then we have the more complicated forms in which the bugs is resistant to almost everything, which is the extreme drug resistance. But we also have the monoresistant forms that are complicated, the treatment and the options that we have. So the other reason is that, unfortunately, we have according to WHO, around 25% of the world infected with TB. Okay, we don't know how many drug resistance, mono, whatever type of resistance. Leave it there. And then the other thing is that we have a large number of people that die with TB because of drug-resistant TB. According to WHO, that's 160,000 people a year. That puts a high proportion of it's actually in top 2 killers of the AMR if we take that figure of WHO, which looks at, so it's, what I'm trying to create here is the burden picture, okay? So, but and WHO recognized that, but by including TB in the critical pathogen list that was just issued, I think 10 days ago, so recognizing this problem. But the other problem that is actually very scary is, and you discussed already, is that we don't have too many, we have only few new drugs, the bedaquiline and the lamanid. We don't have any new options. If we lose bedaquiline because of the poor access, because of people interacting, before of God knows quality, before of bad management of people interact, we are doomed. Not me working for Stop TB, all of us, okay? Because the options of treating drug-resistant TB will be dramatically reduced. So I know we will speak about access and so on. So what we advocate for, I don't think the time in which, and I very much understand, support your point about malaria, the time of looking at this disease and their contribution to AMR separately, it's past. So we need to think all together how we can contribute and decrease the number of people suffering of AMR, whatever angle we look at. And there can be some smart ways of doing it by investing in smart tools that are not just for one disease, but for multi-diseases. And I can speak a bit later into that. But that's
Thank you. Thank you so much. Dr. Otto, there's been a very slow global response on AMR. What do you think can be done to change that? And I'd be interested in your perspective. I personally have seen more AMR conversations at this WHA than kind of the previous one. It seems like there's a little bit more traction in the global conversation. Would you agree, or are we a long way off?
No, absolutely. This is the year, but it's not the year. We need to go further. But of course, the high-level meeting that will come up in September has obviously been a very important lever. So many more stakeholders and groups are acting now. And there are a lot of commonalities across. I agree. But I have a long list here. Starting with behavior change, I think we need to, I mean, if we know more or less what we're talking about here in the panel and the expert groups and so forth, but you talk to people, they don't know anything about AMR. We simply need to change the language, the understanding of what we're talking about. Talk about diseases instead. And for me, the bacterial infections are key. They travel with us, within us, between animals, and within the environment, in the One Health perspective. So I think we need to include much more experts from behavior change, social sciences, anthropologists, and really make a case for changing behavior and awareness raising in all countries, context specific. This is a big tall order, but it needs to happen, because if people don't know why to go to an antibiotic, why stay away, we can't get anywhere. Behavior is key on that level. On R&D, I would call for nothing less than a global research institute across sectors on drugs, vaccines, and diagnostics. We simply need to do better. We are failing, and if we lose one, and you said that as well, we are out. So that's really another one. Then on the national governmental level, I think an easier win is to implement water and sanitation in all health care facilities, infection prevention and control. This can save hundreds of thousands of lives. You know that the Lancet series come out just now telling us that. We knew it before, but now we have the figures. And also on the national level, we need to make governments to collaborate. The issue is sitting mostly with the Ministry of Health, maybe sometimes with the agriculture minister and environmental minister, but not with the finance ministers. Why not? We need to build a case for a cross-governmental action on these issues. And the same thing is on the global level. We have the quadripartite, the four important organizations within the UN system, but there are many more that should act. UNDP, UNESCO, others. We need to have a broad, UN cross-cutting collaborative mechanism for accountability. So it's a long list. I hope that this high-level meeting will trigger at least some of this to happen.
Thank you. And to bounce off of that, Jeremy, if you could talk about the significance of the UN high-level meeting and what you hope comes out of it.
Absolutely. So Otto, as Otto was alluded to there, really, we're not going far enough or fast enough in the global response to AMR, and there's been a great deal of collaboration across the system. The quadripartite, I think, is much stronger than it was several years ago, but we're still at the point where we fundamentally need a step change, and we're trying to think about how we can use the UN to deliver the step change this year. And I don't disagree at all with the list of things that Otto described there as things that need to happen, but I think we need to be realistic that not all of those things will be solved in a single day, in a single political declaration in New York. So what I'd suggest is trying to think about this in terms of a framework of what are the things that the UN could actually deliver to really kind of change the structure, change the governance of the global response to AMR. And I'd say there's three things to that. Firstly, there's targets. We've lacked them so far in AMR. We've seen in other areas of global health and climate change, it's been really important to have very clear metrics of what success looks like and being able to keep track of progress towards those. It's a cliche, but what gets measured gets managed. And we've been lacking that so far in AMR, but we should be moving towards that now. There's I think a long list of things you could write targets, very kind of technical targets about for AMR, but the most important thing the UN can deliver is a political statement, a political commitment, something like 90-90-90 for HIV or 1.5 degrees in climate change that can kind of be the goal, the target that can unify efforts and really drive things forward. The second thing is an evidence panel. There's been lots of talk over the course of this week about this and the idea of having something like the IPCC for AMR to make sense of the growing pipeline of research we have out there and help guide governments, help prioritization of efforts, and help keep track of things like drug-resistant TB and drug-resistant malaria, which don't always feature as much as they should in the AMR conversation. And then finally, there's follow-up mechanisms and really making sure that once we've got the targets, once we've got the evidence base being used in a more systematic way, how can we make sure that we're really making progress against that? We need something more than just high-level meetings every 4 or 5 years at the UN. We need something more than just the World Health Assembly to keep track. We need regular moments every couple of years maybe to bring ministers together and really focus across multiple sectors on what progress is being made and review progress and guide prioritization going forward. So that's the kind of three things I think we could deliver from this year.
Now, turning back to access, Dr. Lucica, drug-resistant tuberculosis can be a very expensive treatment process for individuals, which reduces access. Your organization announced a price reduction last year for a critical TB drug. Can you talk about the importance of pricing of these drugs and kind of other barriers to access and how to turn that around?
Yes, and this links somehow to what was already said. So yeah, in Stop TB, we have a team called Global Drug Facility, and there was a lot of work with the private sector constituency of our board and so on. So there was a drop in this important component of the drug-resistant treatment of more than 50%. But the cost remains high. It was it remains high comparing with the normal TB, several times, 6-7 times at the best. And unfortunately, and this is not just a TB problem, I know it's malaria problem, is not that much of HIV problem. The funding is really, really, really limited, and we don't have the resources. And this is the drama when I hear about all the research and all the investments that we have. They will never deliver as far as they don't reach the people. So access is huge. And in TB, I'm for sure it's not just for TB. The population that we work, the people with TB have the most vulnerabilities, and they are not the easiest or the lover of the coverages of newspapers or magazines. I consider reaching the people with TB an indicator for reaching UHC, because they are having so many associated things. So what we do for access, and that's linking somehow with what you just said, both of you. What I think is needed in the AMR, and I agree completely with the point on behavioral change, that takes time, and it takes repeated messages to come. It needs a huge involvement of communities and civil society, and a huge demand. And we are pushing for this in terms of access as well. And what we can offer from Stop TB side, we have a funding mechanism in which we currently have 300 organizations, grassroots at national level, that we are funding as advocates and pushing forward the TB agenda. But it's not just the TB agenda, it's drug-resistant TB, and why not? They will be dying of resistant malaria or so. So what I'm offering is to really look and sit together. And actually our people went to the multi-stakeholder hearing in AMR, and because they were so vocal, they were the only one visible, because they have no shame, and we should have no shame. So I think what I want to say is that the access will not be sorted out without the involvement of people affected. And what I think will strengthen the discussion on AMR is engaging a huge number of civil society and advocates and communities, understanding the topic. I think somebody said about the language and what is said, and also embracing it. And I think with this, we can achieve much more. The last thing that I want to say is this. On the UNHLM, there are, and I know we are looking together with several colleagues from UK and others, and we have some key asks from the TB community for AMR, but there are things already negotiated and agreed last year, including targets for example, for TB, that are an easy win to be already there, because there was already a negotiating happening, so it's countries are going to be in a difficult position with all these negotiations. So already things that were approved, it's easier to push in there. So just a tip. Thank you.
Thank you. Carolyn, so your ganaplacide lumefantrine combination drug is in phase 3 trials in a few African countries. What are you hoping to prove in these trials, and what's the timeline? When could communities potentially access this drug?
Thanks for the question. So this is ganaplacide lumefantrine, which is just going into phase 3. And I have to say, we partner very closely with the WANACAM2 consortium funded by EDCTP and Medicines for Malaria Venture, who help us to execute the trial successfully. But it started a couple of months ago. We actually are enrolling patients in Democratic Republic of Congo at the moment. But actually, because 95% of the burden of Plasmodium falciparum, that's the most virulent parasite that we have for malaria, that's in sub-Saharan Africa. So our trial is being conducted mainly in sub-Saharan Africa across 14 different countries, also in India, because they have a small burden as well. But actually, what we're trying to do is go quickly to the communities that actually are going to benefit from the drug, make sure we're studying against the appropriate target population. So also the majority of patients that get malaria are children. So actually our phase 3 trial has adults, has children down to 5 kilograms body weight. That's just under 6 months of age. And we think it's really important to study those patients who are the ones that are likely to need the drug in clinical practice early. So actually what we're trying to show is that we're looking at the effect of ganaplacide lumefantrine in adults and children with acute uncomplicated malaria. We're going into those areas where resistance mutations are occurring right now and where it's a problem. So we'll hopefully be able to demonstrate that actually the drug, the combination, is completely effective at clearing those resistance mutations and stops them spreading onward. We're actually going to be demonstrating the efficacy against the current gold standard therapy. And there's actually a WHO standard of 95% patients of cure rate at 28 days. So that's the target we're going for to demonstrate in the trials. But I think one of the interesting aspects of this phase 3 combination is that it actually, not only does it treat the infection, but it actually kills the sexual stages of the parasite. So hopefully it stops the infection being transmitted on through the mosquito. And we think that's a really important attribute, which is going to help curtail the onward infection. So we hope to complete the phase 3 study next year, and then obviously to go through the appropriate health authority approvals and get the drug out to communities as quickly as we can. But if there's a public health emergency in the meantime, because of the emergence of resistance, we're already thinking about how can we get the drug out to the communities that need it.
Wonderful. Well, we're unfortunately out of time, but thank you all so much for joining us.
Thank you.
Well, thank you, everyone. I'm very pleased to introduce you to my colleague, Catherine Cheney, who was actually supposed to be joining us this morning and had a little flight mishap, but she is one of the masterminds behind our programming here. So thank you so much, Catherine.
Thank you, Kate.
Well, thank you all for joining us today. We, again, want to thank our partners that make doing everything we do at Devex possible, and especially our events here at WHA, our impact partners, HemoQ, Evolution, MSH, Nora Health, One Site Esler Lexitica Foundation, Qualcomm Technologies, BlackRock Technologies, and the United Nations Foundation. Also, our ecosystem partners, we have Ferring Pharmaceuticals, ISN, Medtronic Labs, MSD for Mothers, and Roche. I thank you all for supporting us. Also, I thank our Devex Pro members for supporting our journalism. We are going to have more going on this afternoon. We'll be back in this room at 2:30 for an event with MSD for Mothers. And then we have an action-packed day tomorrow. Catherine, maybe you can give us a little glimpse on what we can expect tomorrow.
Sure. Yeah. For those of you here or those tuning in online, and that was me earlier this morning, given my flight mishap, a really exciting agenda tomorrow. Lots of one-on-one conversations. Some names you would know, like Dr. Jean Kaseya from the Africa CDC will be joining us. Some names you may be less familiar with, but should know. For example, Dixon Jabanda, who started Friendship Bench, a model for mental health that's really spread across the world. And we're going to tackle a range of topics like tech in health, health in humanitarian settings, and one session I'm really looking forward to that gets very practical on how to partner with ministries of health. We've talked a lot about government partnerships, but how do they really work? What are the challenges? What makes them successful? We'll dig into that tomorrow. And you can follow this by tuning into our coverage, tuning into our summit, as well as our coverage. In addition to this summit, we have coverage on our newswires, our daily newswire, also the Devex CheckUp newsletter you've heard so much about today. And we also have a special WHA podcast. So make sure you're signed up for our newswire and for CheckUp to get those details in your inbox.
Great. And then also tomorrow morning, we will back in this room starting at 8 for a breakfast, an event with ISN on kidney disease and last mile care. And then at 10:30 with Medtronic's lab for an event on AI and healthcare. So please join us for either of those. And then we'll kick off the second part of our summit tomorrow with a lunch starting at 11:30. And then our program will start at 12:30. Followed by a reception. So lots more to come. Again, thank you everyone who joined us today in person and joined us online. We hope to see you now at our lunch break that'll be just around the corner to the elevators. Our colleagues outside will direct you if you have trouble finding it. We hope you can join us there. But thank you, everyone.
Thanks, everyone. Thanks, Kate.